So I will teach you on how to read CTT, on how to know if it's abnormal or normal, or what will you do if maibot siya. Okay, klaro ba ang audio, class?
Yes po, ma'am.
Okay, sige. Let's start. If you have question, you can type lang ha on the chat box and I'll answer also. By the end of this video, may additional pa ako na topic na i-discuss. And then, but na siya sa inyong PDF na akong gisend last week. So, please check your PDF. Naana na mga PowerPoints na ginamit na ito. They discuss ito kalo na dito sa inyong PDF. Okay, sige, let's start. Okay. So let's start with COPD. So I think class, no? What comes into your mind when you say COPD? Ano ang meaning ng COPD?
Chronic obstructive pulmonary disease po, ma'am.
Yan, very good, no? Correct. Chronic obstructive pulmonary disease. When you hear COPD, ano papasok sa utak niyo first class? Ay, di ba pa na ako na-discuss, no? COPD. Sorry, marag nag-dream pa ko karon. Marag feeling na ko na-discuss na ako sa inyo, ha? When you say COPD. When we say emphysema, this is alveolar breakdowns. Nasisira yung alveoli. What comes into your mind pag sinabing alveoli? This is where the area of oxygen and carbon dioxide exchange. No? Dito yun nangyayari. So what happens in the alveolar class is it's destroyed. No? When you say alveoli kasi nagakuan na siya, another problem when you say obstructive. There is an obstruction in the lungs. And chronic bronchitis. Ay, hindi na later ngayon. So you can see here on the right side, class, the difference between the emphysema and the bronchitis. Now, when you say bronchitis, this is the inflammation, no, of your bronchioles, and there is also a production of excess mucus. Wait, let me annotate. Ayan. So kung nakikita ninyo, class, no, there is a small pathway na lang for the oxygen to pass through. Plus, meron pa yung mga plema-plema dyan. Okay, ganun. Okay? So, paano na tayo maka-inhale and exhale? Another problem when we say obstructive pulmonary disease is emphysema. When we say emphysema, this is alveolar breakdowns. Nasisira yung alveoli. What comes into your mind pag sinabing alveoli? This is where the area of oxygen and carbon dioxide exchange. No? Dito yung nangyayari. So, what happens in the alveolar class is it's destroyed. No? When you say alveoli kasi nagakuan na siya, naga-expand and kuyos, no? Naga-expand, naga-recoil din yan ang alveoli natin. So what happens when there is emphysema? Wala na, nasira na siya. So the recoil process and the oxygen and carbon dioxide exchange is also not functioning well. So anong nangyayari sa oxygen ng ating patient or oxygen saturation when you take the SpO2? What do you think is the usual result?
Lesser than below normal po, ma'am.
Yes, very good. Correct. You're using your critical thinking. Very good, no? So common sense will tell you if there is a difficulty of breathing and the carbon dioxide and oxygen exchange is inadequate and the lungs is obstructed, papasok sa isip mo, mababa yung SpO2 result mo when you check it. Okay? So pag sinabing COPD, this is a long-term problem, class. Hindi ito pares na ubo. COPD na agad. Hindi yan siya ganyan. Okay? At saka, kung iinom siya ng gamot, mawala na yun ng ubo. Dili na siya ingon ana. Okay? Pag COPD. This is a long term. May hinahinay gina-destroy, no, ang kanyang alveoli and the constriction of the bronchioles. Next, progressive respiratory disease characterized by a combination of signs and symptoms of emphysema and bronchitis. It is a common disease affecting tens of millions of people and causing significant numbers of deaths globally. There are two main forms of COPD. Sinabi ko na ito, the bronchitis or chronic bronchitis and emphysema. What are our risk factors when you say COPD? Ito, lumabas ito sa quiz B, no? Smoking. One of the number one risk factor of patients having COPD is smoking. Sa mga kalaan natin yan. Parayosi. Very good, correct. Yes, correct. Smoking is one of the first risk factor. Kaya kung mayroon kayong kakilala, no, nagayosi or kayo, iwasan nyo na. Okay? Kasi remember, when we say smoking class, second-hand smoker can also be affected with COPD. Okay? Di ba? Mas malala pa ang second-hand smoker. Okay? So, layo-layo na gid gamay. Okay? Another risk factor is air pollution, exposure to industrial chemicals, and hereditary deficiency of enzyme alpha-antitrypsin. Itong enzyme alpha-antitrypsin class, no, this is enzyme that is present in our lungs. No, this will help the lungs to inhale, exhale properly. Okay, so here is the photo on your right side. This shows you or visualize what happens inside the lungs of a COPD patient. So tignan nyo, no, ang kanyang asan na itong annotate. So as you can see, no, asa mo agi ang oxygen. No, what na agihang way buslot, no, wala pathway for the air to pass through. And what happens in your alveoli, no? So it's already destroyed, buslot na. This is not how the normal alveoli looks like. So this is the visualization of the inside of the lungs of your patient having COPD. So let's differentiate them both. Or wait lang, next. Here, side by side, we will try to differentiate and discuss between emphysema and chronic bronchitis. So again, when we say emphysema, this is the destruction of the alveolar walls resulting in decreased elastic recoil of the lungs. Again, there is a expansion and recoil of your alveoli. So kung merong destruction, paano niya yung gagawin? Okay? And alveoli is the location of exchange of your oxygen and carbon dioxide. Paano yun mangyayari kung destroyed yung alveoli? Okay? So there are types of alveoli destruction. Here is, as you can see, no, and we have panacinar and centreacinar. But when you say panacinar class, it involves alveoli and extends to the central bronchiole. So, sinabi dyan, class, pag panacinar, ang affected, no, na pag-destroy ng kanyang alveoli is nag-extend until the bronchioles. Hindi lang yung alveoli lang mismo, but nag-extend pa siya sa mga smaller bronchioles na naka-attach doon sa alveoli. When we say centreacinar, wait lang, makita nyo ba? Or putol? Or may naka-cover? Ayan.
Recover, ma'am.
Yeah, gitanggal ko na. Kita na. Sige, thank you. So when you say centreacinar, actually nandun yun siya sa PowerPoint, sa PDF na isend ko sa inyo. Okay? Para maka-annotate mo. Okay? When you say centreacinar, affects the bronchioles in the central part of the respiratory lobules, no? So as you can see in the photo class, no, here is an example of centreacinar. You can see, no, the bronchioles is also affected. Nag-extend siya dito. Here is an example of the panacinar. No, the alveolus and the alveolar duct is affected. Ganun ang mukha niya. Iba ang mukha niya. Okay? In comparison to the normal. Ito yung normal class. No? Ganda, no? Yung color blue. Yung merong mga destruction, that's yung mere color red. Okay? On the other side, wait, let me clear all my drawings. Kay marag govot. On the other side, we have the chronic bronchitis. When you say bronchitis, anong papasok sa utak niyo? When you say itis?
Inflammation po.
Very good. Inflammation. Do not forget that, no? Inflammation. Very good. I can see people are chatting on my chat box. Sige. Inflammation of the bronchus. Kasi sinabi niya bronchitis. So, asang inflammation? It's in the bronchus. So, it is where the excessive mucus production with a productive cough and impaired ciliary function with decreased mucus clearance. So, this is what we call the smoker's cough. Okay? This is what the layman's term that they use, no? This is the repeated lung inflammation and it damages the lungs, causing a scarring of the airway. So it would look like this, no? Mag-constrict yung bronchioles, no? Because of the inflammation, no? And because of the inflammation, there is a production of the mucus. Okay? So that is why, no? Wala nang madaanan ang air natin doon sa ating lungs. Let's proceed. So how will you differentiate an emphysema and a chronic bronchitis patient? Here is an example of the difference between them both. When you say emphysema class, what comes into your mind? Always remember pink puffer. Okay? Pink puffer for emphysema. How does they look like? They appear old and thin. They appear with severe dyspnea. When you auscultate their lungs, you will hear quiet chest. Bakit quiet chest? Because the alveoli are already destroyed. No? Wala ka masyadong naririnig. No? Then the X-ray hyperinflation or the hyperinflate na masyado yung lungs, ganito ang mukha. Okay? Wala, hindi mo masyadong ma-appreciate. Okay? Wala masyadong bronchioles, hindi mo masyadong makita yung parts, ganon. And when another distinct sign of emphysema is the barrel chest. Okay? Nandito ba? Oh, yes, the barrel chest. For a normal person, di ba class, we have the 2:1, no? Anterior, posterior, lateral, hindi iyan sila pantay. No? So, here, ganito ang mukha ng barrel chest ng patient, no? 'Di ba usually hindi ito pantay, your anterior, your posterior and lateral. Okay? Hindi yan siya pantay class, no? But what happens into your patient with barrel chest, pantay siya, no? So it would look like this. Parang overextend ang masyado anterior at posterior part of your patient. Okay? This is a distinct sign that the patient is having prolonged hypoxemia. Okay? Next. So there is also a sign, no, of reduced ability to exercise or do strenuous work. because of the effort of the lungs. And then productive cough, dyspnea with minimal exertion. So konting galaw lang, gihangak na. Okay? Next, let's proceed with the chronic bronchitis. For the chronic bronchitis class, always remember with the blue bloaters, no? Blue bloaters. Why? Because patients with blue bloaters appear, no, cyanotic. Okay. Cyanotic sila, they appear cyanotic, kaya blue. Then, they look overweight. Bloaters, remember bloaters, parang edema to sila tignan, no? Hupong tanawod. Eh? Kaya bloaters. They have elevated hemoglobin because the body is trying to compensate. This elevated hemoglobin class, no? Alo, taas at RBC anyo eh. Diba RBC? HbA, so when you check hemoglobin, yan, in your CBC, complete blood count, no? Yan, magpa-ano kayo, magpa-PA, physical assessment, kuan magdugo diri, that's CBC. When you check the parts of your CBC, you check the hemoglobin, no? So when you check hemoglobin, mataas. Bakit? Because the body is trying to compensate, to produce more hemoglobin in order to compensate the decreased oxygenation. Because the body is thinking, ala, konti ilalagay ang oxygen. So produce pa mo ng hemoglobin, Pero thinking lang na si lungs pala is inadequate to inadequate lang talaga to have the exchange of the carbon dioxide and the oxygen. So yung body mo, yung hema system mo is producing hemoglobin more to compensate. Now remember, hemoglobin is the one who's carrying your oxygen. That is the conductivity of your RBCs. That's why doon papatong si oxygen. Okay? So thinking niya, masasolve niya ang decreased oxygenation sa body by producing more hemoglobin. Okay? Next is peripheral edema, and there is a presence of bronchi and wheezing upon auscultation. Okay. So, ma'am, pwede ba duha? Pwede. Pwede po isa, pwede rapod, no? But there is also signs of combination usually, okay? So, diagnostic. What are the diagnostic tests that we can run for our patient who is having COPD? We have pulse oximeter or yung SpO2 ninyo. We can detect if there is already hypoxia of your patient, if decreased at normal levels. Like, ma'am, magpanik, okay, class. In a scenario in your board exam, if ang problem is COPD, diba sabi ko sa inyo, that is a long-term problem. So, usually, the result of their SpO2 is low, no? Kasi obstruction of the lungs yan, expected. That is expected. So, kung SpO2 mo patient, ang nigawas kay 90, 91, diba, mababa na yan, no? 95 to 100 na atong ato ang ano. So, that is one of expected, no, signs and symptoms of your patient. Do not panic muna. Okay, basid nagpanic na ka nang i-intubate na ni mga patient dayon. Okay? So those are expected because of the obstruction, kaya naga-reflect sa SpO2 mo mababa. Okay? Next, chest x-ray, no? So check the lungs, no? Ano nangyayari sa loob ng lungs? ABG, no? Arterial blood gas to check if there's compensation, no? Of your respiratory and metabolic. Spirometry to practice the lungs, to inhale, exhale. Pulmonary function test, the CT scan, and the checking of the alpha-1 trypsin screening levels. So all of these diagnostic tests you can use to make to check for the diagnosis of COPD. Let's proceed with the grades. Ma'am, na grades ang COPD? Oo, na ay grade 1, grade 2, grade 3, grade 4. Okay? Eskwela po din sila. No, this varies from the severity of the COPD of your patient. When you see grade 1, no, the grading of your COPD is grade 1 if it is mild, no? If it's grade 2, if it's moderate, grade 3 if it's severe, and grade 4 if it's very severe. So this one based on the result of your pulmonary function test. No? So kung magtitest ka ng pulmonary function test, ano yung result doon, i-compare mo dito and you will know what is the grade of your patient. Okay? Yan. FEV is forced respiratory volume, no? FVC is forced vital capacity. Ito yung how will I explain? Your lungs, di ba? Naalang na capacity ang lungs mag-inhale. Ganito lang na amount, no? And usually pag mag-exhale ka, dili man tanan ng air mo i-exhale, meron tayong maiiwan na konti, okay? Para mabalik yan sa inhale. So yun ang gina-measure nila, okay? The expiration and the capacity of your lungs to inhale oxygen. So with that, in the treatment of your COPD, in line with that, with the pharmacological medication is giving of puffs, no? So I think, no, some of you are familiar with using this. Kasi may mga asthmatic diri, mga asthmatic na to, wala.
Excuse me po, may tanong lang po ako ulit, ma'am. Saglit lang po. Yung FEV po, ano yung FEV po ulit, ma'am?
Forced expiratory volume. Ito yung ipa-exhale mo ang patient forcefully. Anak, mag-blow na sila dito sa pulmonary function test. I-measure niya how amount yung na-exhale mo. Okay? Gano'ng kadami? Okay? Ng air. Yun ang forced expiratory, yung at to the end niya talaga, na wala na siya maikagawas na air. Okay? Yan. Ang capacity,
thank you po.
Pag mag-inhale siya, gano'n din kalami ang napapasok sa kanyang lungs. Ganon. Okay? Sige. Thank you. You're welcome. Balik tayo doon sa mga bronchodilators natin, di ba? from the word itself, it will give you an idea. Pag bronchodilators, it dilates the bronchos. Diba? Ano lang na mag-study common sense in nursing class, no? Diba? When you say COPD obstruction, anong ibigay mo na gamot? Papadilate. Diba? Bronchodilators. Ganun lang, no? When you study and try to use your critical thinking, simplihan mo lang. Huwag mo nang hirapan ang sarili mo. Okay? Use your common sense and critical thinking. Pag alam mo COPD, merong obstruction, kailangan natin i-dilate yan kasi constricted. Kaya, that's why we give bronchodilators. But the question is, kung walay kabalo diri mo gamit ani, or walay asthmatic diri, dili mo kabalo mo gamit ani. Kay kabalo ko, wala na hitudlo sa funda, 101. Or I'm not sure kung gitudlo pa sa yung pharmacology, 20, ang boton sa yung pharmacology na ano number. So, let's talk about bronchodilators class. You will see a lot of kinds of bronchodilators, no? But masingunsa pa na siya na klase class, the concept of administration of bronchodilators are the same. So, same na po imong health teachings. So, who will teach our patient? Kita, the nurses, di ba? So, dapat mas knowledgeable tani. Okay? But the question is, kung di kabalo ang imong nurse, or ikaw, the student nurse, di ka kabalo, how will you teach your patient? Okay? So, you have to listen. Taba ko slides, ani? Wala di ko slides on how to teach you. Sige, ako na lang maturo. Sige, wait lang ha. Sige, magfunda sa takadali ha. Funda kadali. No? When you have your bronchodilators, kamo na sa akong spelling ha. Nagsabot na taan ni class. I-try na ko. Kung best, wait lang ha. Annotate. Naman ni siya text good. Perfect. Bronchodilators. So what are you gonna do? Diba? First, hulog. Always check the medication. Diba? Basing mali. Basing di dahil bronchodilators. No? Does it looks like lang. Next, you have to check the medication if it's the right medication. Always naman asin nyo, diba? Funda 101. Check if the medication is correct. Check if the patient is correct. Right medication, right drug, right dose, right administration, right mode. Chu. Padaghan ato, 14 na kabuok. Sa una, 5 lang. Karon 14 na. Anyway, dili na ako mag-dual ato. So, mabalik na ta sa tungang administration. You check the medication. Check the number. Number and expiration. Ma'am, unsay number na? Di cellphone number ang ato ang ano, ma'am? Ang ato ang kaning ato ang bronco. No, there's no cellphone number. Number of pots that are available. Basig, wa na to'y sulod class. Di pa puff pa ni mong pasyente. Wa na di siya ma-feel na gamot na nagasulod si ang baba. No? Imbis, ano na siya, placebo na di imong gibot, hangin ng imong hatag sa iya ha. So you check the number because at the back of that, meron yan siyang number. Hanapin mo lang. Okay? 10, kung 10 lang nabilin, sometimes number of pops left or sometimes number of pops to be given. Basta na ay number dito. Okay? Kung dili to 0, pwede pa. Okay? Check the number and expiration. Okay, basi expired din yung hatag. After that, no, nanasay mo ka mo, sure na ka, perfect na ma'am, shake. Ang tambal, dili ikaw. No? Di ka mo shake. No? Kasi mag-shake ka dito. Shake the medication. Nga naman, some of it is powderized, no? Nanggahi na to dito sa sulod. I-shake mo muna. Okay? After shaking, ganito pag shake class ha, you look at me. Nanana, kung makita ba ko ninyo. Okay? Dili anana. Okay? Shake ang medication. After shaking, no, instruct the patient to place in the mouth. Uy, balik ang spelling. Ay, kakapoy aning kinabuhi. Wait lang. Mouth. Instruct. Ako mo na magkuhan, kaya dili na ma-edit. Instruct the patient to place in the mouth. When you instruct the patient to place in the mouth, hindi po yung buo. Kasi palamon niyo yung tibuok kuan, no? Buko dali, ano pa, tatong mouthpiece lang class. May bawa na nimo ang mouthpiece kay na siya taklob. Remove the taklob, remove ang taklob ha. Kay basig inyong di ano taklob, wala mo gawas mamalangan sirado man na may taklob. Sabi ang mga no nurses kay basig syunga po, no? Tanggala sa ang taklob, no? And then place the mouthpiece into their mouth. When instructing the patient to place it in the mouthpiece in the mouth, kailangan naka-close gyud, walay hungaw. Kay kung hungaw na siya, mugawas ang tambal, sayang. No? To tell you class, this is worth 1,000 plus. Near 2K na ang mga ganito class. Mahal yan siya. Okay? Mahal yan sa mga pasyenteng mga asthmatic kasi ilang beses sila atakihon, ilang beses sila maggamit. So mahal na yan. 2K, laliman ka, asa ka mamon itong 2K. Instruct the patient to put the mouthpiece into their mouth and close it na walay makagawas na tambal. And then, instruct them to inhale, exhale. Inhale, exhale. Then, ask them to puff. Puff. Inhale, exhale. Inhale. Ano magsulat? Exhale. And then, pag inhale, exhale, pag exhale, no, you tell them to puff. Pag sinabing puff, i-press nila yung gamot. Ika isa lang. Okay? Di po na to. Ano, magkabuang ang pasyente suyop sa tambal, no? So, one puff at a time. So, pag press, instruct the patient when after pressing the puff, no, inhale. Suyopon. Di inhale sa ilong. Ano, di, gibutang ang mouthpiece sa ilong. Diba? Common sense ba? Gibutang sa mouth, mag-inhale. Eh? So, ang sa nagyod, alangan naman i-mouthpiece. Nosepiece, to siya, next time, no? Atong i-suggest sa nagbuhat na nosepiece sunod. So, mouthpiece man siya. So, instruct the patient to inhale in their mouth. Inhale na, dili exhale. Di ba? Inhale, exhale. Inhale, exhale. Sir, pag ready na ka, puff, suyo pa ang tambal. Okay? So, pag suyo ka na, maka-feel na siya nanay, musulod ng mga powder na sa kanyang baba. After, inhale. Inhale. Yan. Wait lang, ha? Inhale, mouth. Inhale. After the inhalation, instruct the patient to hold. 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 Ano itong i-hold? Ang ginhawa. Stop breathing, sir. Stop breathing for how many seconds? No? 1 day. Chat lang. Hindi. 10 seconds. 10 seconds, good ma'am. Yes. Unsa naman ng 10 seconds? 10 seconds. Pag puff, 1,001, 1,000. Di siya mustorya ha. Kaya magawas ng tambal. Kaya lang niya sa kamot. Kung makita sa mga movie, ang mga bata, hawag kayo ng mga inhalators, mag-anaan na sila kamot. Okay, we are counting at the same time. Pag suyok, 1,001, 1,002, 1,003, 1,004, 1,005, 1,006, 1,007, 1,008, 1,009, 1,010. Exhale. Sige daw. Tanaw natin yung critical thinking and inyong analogy. Nga nung gipa-hold na ko ang patient og breathe. Wala lang na, para mamatay siya sa'yo.
Para mubaba ang tambal ma'am. Para
mubaba mo na og di ay, musulod sa lang.
musulod di ay.
Musulod ha, musulod ay. Sige, tama. But you have the, nana ka sa point, no? Musulod sa lungs. Kaya kung mo, pag inhale, pag puff, so yung patient, ni-exhale siya dayon, sa ilong pag yun. Nigawas ng tambal dito sa powder, sa ilong. Kaya di ba na may agianan, from your mouth to your nose, na may agianan. So, bye-bye, 1,000, na sa hangin. So, tagat yun siya. Ana. So, that's the why we have to instruct our patient to hold their breath for 10 seconds so that the medication will go to your bronchus para dito mag-take effect. Eh kung dili nimo siya ipa-hold, hangtod sa baba lang na siya. Nya nadadiri ang nadadiri ang constriction, obstruction sa baba nimo. Wala, no? Dili man ni siya broncho baba dilator, no? So ana siya. Use your common sense. So, the common sense will tell you para maabot ang tambal sa imong lungs. Okay? After holding, do not forget to tell to exhale. Okay? Ikaw din dahilan na matay yung pasyente. Remember, this is COPD, no? Wala mo maging na exhale guys, sir. No, after. Okay? After that, especially if you're giving medication, case-to-case basis, you check your medication. If they are having corticosteroids, no, na kinds of puff, do you know what is corticosteroids, kinds of puff? This contains steroid. Patients who are taking these kinds of puff, no, will have aftertaste of metallic taste, no? Murag ikaw sila taya, lasag taya. Anak, matanan niyo ang patient. So, what you're gonna do, your nursing intervention, tell them to, toothbrush? No, just gargle water after taking. Okay? Gargle lang sila. Dili niya, not necessarily niya ipatoothbrush yun. Okay? As long as gargle, okay na. So, okay na ta. Ha, humanap sa funda. Balik na ta sa ABC. Level 4 na ba no? So, balik na ta sa ABC. So, this is our just a short. Uy, dili din ma-erase ang ako ang mga drawing kadalasan. And these are just short pathophysiology of the concept of what is happening in your COPD patient. Overall, the risk factors are already discussed, no? With that risk factors, exposure to everything, no? Radical, smoking.
Class, naintindihan yung bronchodilator. Kasi kayo ang mag-instruct niyan sa mga patient, ha? Dili laing tao. Because I have a lot of experience, maligid ang instruction. O ban, di ba? Kakita mo sa mga Facebook, gi-perfume, no? Gi-perfume ang puff sa iyahang lawas, no? Asa daya nga to ang lungs di ay nanaday sa langit, nanaday sa skin karon. Okay? So please, I hope that you understand, no? Kung na-understand, ano daw be? Approve reaction so that we can proceed. Am I too fast, class? No? Kailang man no, masabtan ka catch up pa bata na ang inyong PDF class nakablangko na ha, so you just fill it up na lang. Okay, thank you so much. Let's proceed.
No? This will lead to lung inflammation. And lung inflammation will lead to bronchial, no, yung inflammation natin sa bronchus, and the destruction of your parenchyma or also your alveoli. If there is bronchial inflammation, no, there will be releasing of the neutrophils. Thus, these neutrophils obstruct the airway, no. Then there will be increased production of your goblet cells and proliferation, as also your cilia cells, katong mga ana-ana sa inyong lungs, katong mga silhig, para mag-release sa mucus kung muubo. Wala na, guba na to siya. So with that, no, with that cilia being destroyed, inadequate na ma-release ang mucus sa lungs. So mabilin ang mucus to. Imagine, no? When you auscultate na asang sa baa sa lungs. So this will lead to mucus trapping. Okay? Ayan. Itong goblet cells class, ito silang, di ba, kumakain, mag-engulf, yan sila. Tapos kakainin nila, tapos patayin nila yun. Ayan. So with that, mag-increase din yung mucus production. So with the other side, dalang parang kain exposure to the lung inflammatory mga risk factors will lead to inability to recoil of their alveoli, no, or decreased airway elasticity, thus leading to also decreased structural support for airway patency. Yun nakita natin yung mga narrowing and collapsing of your alveoli. And then there will be permanent enlargement of alveoli. Ma'am, pag enlarge ng alveoli, nga lang daw busot-busot, pwede ba tumaayo? Dili na, no? Wala tayong reconstruction of alveoli. So kung maguba na siya, yun na gid yun, no? End of alveoli na. Okay? So yon. So with that, all of this will happen, no? Will result you to having signs and symptoms of the COPD. How will we manage this? What are we gonna do? What are we gonna tell to our patient? Syempre, number one rank risk factor is smoking. So, smoking cessation. Ilas po natin ang pag, EOC, no? Undangan ang pag, EOC, sir. Okay? So, smoking cessation, giving of bronchodilators, oxygen. Okay, nabalik diri, Yeah. Always remember how many liters you can only give for a patient who is having COPD. Another board exam question and a quiz B. How many liters lang ang ibigay mo sa patient na COPD? Oh, uy, wala mo kabalo? Ayan, narinig answer. Very good, very good. Dapat yung question mark, so dili sure. Sige. The correct answer, yes, correct, kabalo din sila. Late lang dahil sa kuha ang pag-receive sa chat. So some of you answered in the chat box, 1 to 2 liters per minute. Okay, very good, that's correct. The maximum that only, for those who did not know, no, take down notes, sulat, COPD, 2 liters lang yun, exclamation point. Ngano? Because if you give, masking, baba na dyan kaya ang iyahang class, ang iyahang pulse oximeter, masking, mag-89 pa na, mag-88, dili ka pwede, musaka og oxygen, sa oxygen therapy mo. No? Bawal. 2 liters lang yun. Kahit anong gusto mo pa, hindi na yan pwede. Iakyat pa. Bakit? Kasi diba, we will decrease the hypoxic drive of your patient. Mas pwede pa siyang chances mamatay. Hindi na mag-stimulate ang kanyang lungs to breathe because of the hypoxic drive. That is the only drive that keeps them breathing. No? So kung itumas yung ihatag sa oxygen, mukha na siya, ay, okay na ko, daga na kayo oxygen. Di na ko mag-release akong carbon dioxide. Okay. Diba, mamana siya. Pag mag-exchange man na sila, oxygen inside, tama ba? O, lagi, mag-exchange sila. Masulod si oxygen, magawa si carbon dioxide. Ay mag-exchange sila. Pero kung mahitag, kung too much oxygen ang pasulod, because you administer too much, wala na carbon dioxide. So, wala na siya drive para mo breathe. Okay? So, kung imo nang increase pa, ay, naday dire ang answer. Naday cheat codes sa ako ang slides. But that's correct, no? If ever you very good, critical and clinical eye. Kita dahil sa answer. So, urge the patient to stop smoking, in the bronchodilators, oxygen, adequate hydration, chest physiotherapy. Chest physiotherapy is for the what? Mucus, ha? Takon ang mucus, no? Yun yung pangganito sa likod, no? Sa ating mga RT, respiratory therapist natin ng mga friends, no? Yan, chest physiotherapy. Yes, very good. That's perfect mucus, ma'am. Help facilitate mucus production, ay kanang expulsion. Okay? Nebulized treatments, nebulizer, no? Remember, are you familiar with the nebulizer? Yung parang di pa, inhale, exhale na, smoke, no? Ay, asu-asu. If I inhale, exhale sa patient. Okay? Next, mucolytics, no? This will ipahumok ang plema. Okay? Next, corticosteroids and diuretics. Paion, no? Kasi di ba, we have an episode, di ba, the patient is also bloated. So there is a peripheral edema. So if there's edema, we have to excrete the excess fluid that is retained in your patient. So then, explain the bronchodilators, alleviate the bronchospasm, enhance the mucociliary clearance of secretions. So this we can help this patient through giving medications. Familiar sa patient to describe bronchodilators, teach and informs the correct method of an inhaler. Oh, dito lalata mo ha, teach your patients properly. Kasi, you know, in the area, so gaba lang yun, no? Kung makakita ko na, masuko gid ko, kay ano, gisayang lang gid kwarta ang nurse, no? Wala na tudlo ng tarong ang patient. So, yun, teach your patients, yun. Then, familiarize the patient, strengthen the muscles of respiration, teach the patient to take slow, deep breaths, and exhale through first lip. So, ito na yung lalabas yung nurse intervention mo na deep breathing exercise and first lip breathing. Okay? If you see your patient is having difficulty breathing, nag-dyspneic na siya, anong gagawin mo as a nursing intervention? Okay? So, your intervention with this is deep breathing and first lip breathing, no, na health teachings. Ito na bagalabas yung mga problems sa NCP na, no, area of, ito yung mga NCP ninyo, mga basa, airway ng mga problems. Teach the patient how to cough effectively and help metabolize the secretions. If secretions are thick, and urge the patient to maintain adequate hydration. So, i-hydrate, increase oral fluid intake para mahumok ang lemma. If the patient will continue oxygen therapy at home, teach him how to use the equipment correctly and administer only 1 to 2 liters of low flow oxygen because of the carbon dioxide retention. Either way, pwede ra, pero ginaano sila is nasal kanila. Kay mas gamay low flow lamang god. When you say mga mask, pag mag-mask na gani mo class, katong makita ninyo, whether katong na-IV breather or wala, those are masks if magamit ng mga ato pag mo increase na ang liters of oxygen. Okay? Like 6 liters, kana mo increase naman ka. Dili makapalit 10 liters sa nisal kanila, nasamad na imong ilong. Tingala ka, ma'am, nag-epistaxis sa patient. Alam nga imong nisal kanila naka 10 liters. Gabi ang pressure, ana ba na dito, di ba? Kusog kayo na. Nasamad na iyang mucus, nag-dry dito, nagdugo-dugo ng ilong. Alam nga nisal kanila pa man ka at 10 liters. Dili man pwede. There are only minimum, no? Pag nisal kanila, ingani lang na liters. Pag mag-mask, ingani lang po na liters. Okay? Yan. Next. Okay, we're finished with the COPD. Let's proceed with the pulmonary embolism. Oops, sorry. Pulmonary embolism. What comes into your mind? Pulmonary embolism?
Na ay embolus, ma'am.
Embolitis lodge, emboli. Na napunta sa lungs. Okay? Dili embolus, nag-form og emboli sa iyang lungs. Dili ha, panduslakon ta mo ron. Okay? So there is a dislodged emboli that goes sa imong lungs, no? Kaya nagkuan siya, nag-obstruct doon. So hindi na makaginhawa ang patient. Okay? What are the common causes? Mamaya. Excited na ko. Excited to discuss. So, pulmonary embolism, from the word emboli, no? Embolism, embo. So, pag board exam, pulmonary is...
Okay, questions with COPD? Wala. If there's no question, approve reaction pa so that we can proceed. Okay, sige. Thank you. Kung if you have question, please type it in the chat box. Thank you.
Embolism, kabalo ko na naay kung embolus, no? Na nagpunta sa kanyang lungs. Pulmonary. Which is pulmonary? Lungs. Ayaw pa nga mag-next. Lag na. Last, inako, nag-lag na ko ha, or nag-choppy na ko kay nag-lag ako ang screen. So, di ko sure kung ako internet or ako laptop na kailangan palitan na og bag-o. Charot. Wa kay budget. Sige. Yan, very good, no? Nag-answer sa chat. Kulang kasi when you say emboli lang. Sludge emboli. So let's discuss what is pulmonary embolism. Pulmonary embolism is a life-threatening. Pag sinabing life-threatening, kaguol na, no? Mamoblema ka na. No? If ganon, if that's the case. Ano highlighter? Ayan. There is a life-threatening disorder typically caused by blood clots in the lungs, no? Where emboli mechanically obstruct the pulmonary vessels and cutting off the blood supply to the section of the lungs. So if this is your lungs and that emboli goes here, no? Nag-travel siya, no? Butang siya diri sa may diri na area. So if there's obstruction there will be infarction on that area. Dili na makagay ang oxygen. Obstructed man, so dili na maka-supply ng oxygen doon. If there will be no oxygen supply, later on, there will be cell death. Diba? Yan. So, where are the clinical manifestation of a patient having pulmonary embolism? There is dyspnea for no apparent reason. No? Katawa pa mo, tanatan-aw ra mo TV, no? Netflix, nikalit lang, dyspnea si patient. No? So, ayan. Then, presence of pleuritic chest pain. Okay? Then, takip niya, or taas na yung RR, taki na, and gasping for breath and appears anxious. Ano na iyang paginhawa? Mura nalumos, mura siya kanang bago lang siya nakaginhawa. Okay? Na, gasping na. And dagko na kay na siya singot, no? Anxious. Kulba na siya, nagapanik na siya, kay nagalisod siya ginawa. Tachycardia, because of compensatory mechanism of your heart, no? If there's a problem in the lungs, such as also your heart will try to compensate. Same, if there's problem with your lungs, your heart, your lungs will also try to compensate. Then, auscultation may reveal crackles or friction lab. If lung infarction has occurred, hemoptysis will happen. And then, what is hemoptysis? Hemo, blood. Tysis, what is that? That is the coughing of blood, ha? Ubusag, may dugo. No? Ubo. No? Some patients have no symptoms at all. Dikalit na siya, di orok, charot. Dili bitaw, dali paspas lang ni pag pulmonary emboli. Yes, coughing. Oh, very good, no? Naadi kinatunaan. Joke lang. Sige, ma-offend, no? Pero that's a compliment. Okay, let's proceed with the types of pulmonary embolism. So, here are types of pulmonary embolism. We have air, amniotic fluid, fat, foreign body, oil, parasite eggs, septic emboli, thrombus, and two more. But the most common in the pulmonary thromboembolism which occurs when venous thrombi chiefly from lower extremities migrate to the pulmonary circulation. Ito yung sinasabi ko, class, no? Common risk factor or cause of pulmonary embolism is DVT. Do you know what is DVT?
Deep vein thrombosis.
Uy, very good. Deep vein thrombosis. Ayan, I can see also people chatting me directly. Deep vein thrombosis. You know what is deep vein thrombosis? Sige, prolong lingkod, prolong tindog, gaya ng ginagawa ko sa buhay ko, kaya nagka-varicose, no? This is the stasis of your blood, thus is making it, no, clot formation. Okay? When that is dislodged, no, pwede na mag-travel. Laglaag siya, no? Punta siya sa lungs mo. That's pulmonary embolism. Pag pumunta sa utak, that's stroke, no? CVA, katong, ay, wala pa man dito na neuro, no? Sa later, sa neuro, mag-start na. Yan, okay? Ma'am, na-air? Yes, class, na-air embolism. Yan yung, kaya nagagalit ako sa student ko. Pag ang IVF, no? Wala gitanaw ang dextrose, nahubasan. Nahubas ang dextrose. Kaya gina-IR. Because we wanted to prevent pulmonary embolism. At 10 cc, yeah, mo ha, 10 cc, kataas, no? Of air that was injected into your patient, no, can lead pulmonary embolism. So no, gyud na ay hangin musulod sa pasyente. That is negligence on your part, di ba? Bioethics, negligence. Nag-neglect sa nurse, no? So, pumasok sa kanyang katawan ang air, no? Kasi naghubasan ka, hindi ka nagpo-follow agad, hindi ka nag-regulate, no? Hindi mo gi-check QRly ang iyong IV. Nagpasok na sa air, no? Nag-travel na yung air sa katawan, pumunta sa lungs. That will lead to pulmonary embolism. Okay? And so on. Okay? So, here are some of the risk factors of our patients who will have pulmonary embolism. So, one of the risk factors is itong mga patient natin naka-bed rest. So, di ba? Mag-duty man mo ICU. Mag-duty na ba mo ICU? Tama ba? Or ongoing na mo?
ER po, new rotation, ma'am.
ER pa mo and then ICU. In our patients that who are on bed rest, naka-immobilize, no? Perminti lang na sila nakahiga. Comatose patient, higda lang na sila perminti. Kaya mga patient natin na mga ganyan, mga bagong surgery, prolonged surgeries, na tig 8 hours ang isa ka surgery, ginabalot na ilang tiil or ginatauran og embolic stockings. Kaya di ba, kung mag-prolong stasis of blood, pwede mag-clot formation. Pwede ma-dislodge, pumunta sa katawan. Kaya naka-embolic stockings yan sila. Okay? Embolic stockings promote circulation of blood in the extremities. So, that's preventing stasis of blood in that extremities. Okay? So, yan. Kung bed rest lang, wala pa dyan embolic stockings, wala pa dyan exercise sa nurse, ang tiil, kumatos yung patient, wala pa dyan ginalihok, high chances of having pulmonary embolism. And another one is immobilization, wala lihok-lihok, no? Low cardiac output states, masyadong mahina ang pag-run ng cardiac output ng heart niya. So, ang blood po, pumping pressure of the blood, hinay lang po. Hinay lang ilang dagan. So, hinay. So, this can also lead to pulmonary embolism. Pregnancy, obesity, hyperviscosity, na sobra kalapot ng dugo. Then, local vascular damage or especially prior thrombosis with incompetent valves, kani sa mga heart problems. Central venous catheters, kani CVC natin, yung sa mga dialysis patient natin, mga access, no? Kanang sa dextrose po din yung class, kanang mga dugo-dugo sa dextrose na wala inyo gipasag, inyo lang gipasagan, wala inyo kanang mga clot formation niya, inyong gi-push, kaya bawal mag-push. Kasi clot yun magpasok sa patient. So, pwede ka magka-pulmonary embolism. Yung mga blood clots sa yung dextrose na tag-asan, no? Change na oy, dili na siguro na to na troubleshoot. Kung matroubleshoot ta, okay, pero kung dili, ayaw na. Change na. Then, CBC catheters ka na, mga access way natin sa ating dialysis. Pwede yan, mga clot formations there. Increasing age, no? Mga old age natin. There are also, for increased coagulability, there are tissue injuries, malignancies, presence of lupus anticoagulant and antiphospholipid antibodies, nephrotic syndromes, and oral contraceptive use, kanang mga mag-inom pills, no? Na prone sila for clot formation. Then endothelial injuries, we have the intravenous catheter placement, trauma, surgery, and deep vein or venous thrombosis. For the symptoms, we have what we call clinical triad of pulmonary embolism. Pag sinabing triad, tatlo, no? So, the clinical triad is the dyspnea, pleuritic chest pain, and hemoptysis. So, yun. Pagpasok, pag perfect, pasado yung tatlo, present on your patient. Uy, baka PE ito, pulmonary embolism. Again, abrupt ha? Abrupt, ikalit lang. Okay? The most predictive physical findings for pulmonary embolism is not in the chest but the leg. A swollen, tender, warm, and reddened calf that provides evidence of deep vein thrombosis. So, common is the DVT. Let's look at the photo on the next slide. Ayan, as you can see, no? Ayan, there is a fat formation in the lower extremities. If that got dislodged, mag-travel, maglaag-laag siya sa imong circulatory system, and again, it end up in your lungs. Thus, clogging that part and unable to give oxygenation on the distant part. So the cell may die because there's no oxygen. Okay? So how does it look like in your chest x-ray? Okay. Kung, ano yan, practice na kayo, magbasa-basa, lalo na sa mga gustong magdoktor. Turuan ko kayo. When you have a patient, no, who looks like, who have like this na x-ray, magbana-bana ka na. This is pulmonary embolism because there is a presence of the wedge-shaped infarct. Okay? Wedge, murag pizza, no? Diba pizza, anak triangle? Okay, so what happens here? The probable obstruction that happened here is dito na area. Okay. As ang nag-clog, dari ang obstruction. So because of that obstruction in this area, wala na yung mag-deliver dari ang oxygen. Okay. That's the probable, no, distinct sign of a patient in the chest x-ray. The wedge shape, mura pizza, no? Pizza na ka, display sa kanyang x-ray. Another one, for your CT pulmonary angiography, no? Same, parang pizza pa rin. Okay? It would look like this. Yan, sa picture. No? Infarct diri na side. It means it will give you an idea that the infarction located is here. Lain po diri Labray, magsugod na bongkos diri sa tumoy, di ba? Sa tip part, dun siya mag-start. Okay? Yan. So diagnostic test that you can run is a chest x-ray. So you can see this one. For the CT, angio, you can see this one. ECG. Bakit tayo mag-ECG, ma'am? Just to rule out, no? If that, sabi di ba, pleuritic chest pain, no? Chest pain. Di ba? Sabi ko sa inyo, sa assessment pa lang, you have to know and differentiate. If this is, di ba, ang nasa chest mo, lungs and heart laman na. So you have to know, learn how to differentiate them both. So mag-ECG ka para to relieve na, ay, hindi to a myocardial infarction. So tuturuan ko kayo sa ECG kung paano nyo malaman if it's myocardial infarction. Pero, kung hindi, kung normal ECG siya, most probably, the problem is in the lungs. Okay? Next, ABG, to check the oxygen status of your patient. Elevate the dimer because this will increase if there is pulmonary emboli production. Ayan. And VQ scan, katong sa ato ang ventilation and quality, katong kipasuyo. Niya makita sa kuan scans, no? Ayan. So, what are medical surgical management? Ayan, wait. Nanay nag-video kayo rin na side. Next, the body naturally dissolve clots in 7 to 10 days. However, if the embolism is large, a thrombolytic agent might be used. These agents such as streptokinase, urokinase, retaplase, and tissue plasminogen activator or TPAs dissolve the clots and are very effective. However, they must be used within 4 to 6 hours of the clot's occurrence and are associated with the risk of hemorrhage. Class, pag mga clots formation gani, ang makatunaw lang talaga ng mga clot formation, di ba? Again, balik tayo sa pulmonary embolism. Alam mo na merong emboli na dislodge doon sa lungs mo. Na-obstruct doon kaya hindi makaginhawa na maayos ang patient. So what are your management? Tanggalin mo yung clot na kabara. Ay para wala ka ng problema. Okay. And how will you remove that? No? Through giving medications. Dito na papasok itong mga gamot. No? The streptokinase, urokinase, and the TPAs. That medication will help dissolve the clot. No, yung kaunon, mawala lang kahit ang clot. If na-dissolve na yung clot, masulbad na ba ating pulmonary embolism? Yes, pag wala siya, nag-destroy agad yung mga cells at the distant part. Okay? Kung sa x-ray pa lang, wala kang makitang pizza doon. Okay? Hindi pa ganun ka, kalala. Pag earlier. Kaya sinasabi, class, na if the patient is having pulmonary embolism, i-admit mo agad. Punta ka na po sa hospital. Kasi di ba, life-threatening. Sugod pa lang, di na natamuan life-threatening, kaguol na. No? I-admit talaga agad sa hospital. Kasi, time is vital. No, when you say pulmonary embolism, because we can dissolve that emboli that is clogging on that area if within 4 to 6 hours lang. Okay? Magsobra ng ganyan na time frame, hindi na tayo pwede magbigay. Ma'am, sure, good yan, ma'am. Oh, dili na pwede ipugos. Okay? Dili na siya. Parehan siya sa stroke. Ingani ang management sa stroke. Once the patient appears as stroke, kailangan i-admit siya once nag-onset. And time is very vital. So kung maglagpas po ang patient no, na stroke, og 4 to 6 hours, dili na po na siya tagaan. Okay? Yan. So, always judge 4 to 6 hours lang from occurrence. Okay? So, pag nakapasok siya, pumunta kayo ng ER, 3 hours pa lang from occurrence, pwede siya tagaan. Pero kung mag-more than that, 8 hours previous pa, dili na pwede. And that will be difficult for the patient. So, kita mo na yung wedge shape doon or pizza sa x-ray. So, treatment is aimed at preventing extension of the clot and formation of additional clot. So, ang goal natin, dili managhad, no? Ang emboli na makita mo doon sa x-ray. At saka, dili mag-expand pa more. Kung pizza lang siya nagamay, no? Kanang pang Albertos lang, dili pa di maparehas sa pizza SNR, no? Dili nga to kadako. Okay? So next, heparin, a potent anticoagulant medication, is administered via continuous intravenous infusion. Heparin is never given intramuscularly because of the risk of hematoma development. And then, so ID gid ni siya ha. And then sometimes heparin therapy is initiated even before diagnosis of PE. So this will help no the blood to humok. Then, sometimes heparin therapy is initiated even, oxygen is administered as ordered. So, di ba, remember, there is a patient, no, difficulty of breathing. Number 1 is intervention, oxygen, no? Delivery. Then, intubation and mechanical ventilation may be required in some cases. If nahihirapan na talaga, the lungs already collapse, no? Si patient nahimatay na, no? Because of the anxiety, no? And difficulty of breathing, intubate na si patient. Next, warfarin or Coumadin, an oral anticoagulant, is used for at least 6 months following the PE to prevent reoccurrence. So, mag-maintenance siya na siya of warfarin. Okay? So, para dili na mag-occur ang blood confirmation again. Okay? Next, warfarin therapy can be initiated 2 to 3 days after initiation of heparin. Because it has a slow onset of action, it may require several days for full anticoagulant effect to occur. So, binibigyan natin ang patient ng anticoagulant. From the word itself, anti. Prevent anticoagulations of your blood. So, the patient will be on both anticoagulants for a time. So, sabay ha, sometimes nag-heparin pa siya, nag-warfarin pa dyan siya. Pero usually, heparin sa, and then yung warfarin, then sometimes, igagmay-gagmay na lang ang dose, gamay-gamay, ginatitrate bababa, until dili na gyud mag-occur, reoccur. Okay? So, warfarin therapy is monitored regularly for troponin time and INR. Pag naka-mo patient, gani class, pag naka-anticoagulant na therapies or mga medication, ginamonitor always ang prothrombin time and INR nila to check if normal levels pa ba. Okay? Kailangan this laboratory test, these are the laboratory tests that will help you indicate that the therapy is working. No? At saka the therapy is not in the critical kanang tawag nito na sobraan, na overdosage ang paghatag. Okay? Next, in patient with life-threatening symptoms, a surgical embolectomy can be performed, and this is as a rare procedure that is reserved for emergency situation. So, kung hindi talaga naglalan na 12 lang ng gamot, no, surgery is the key. And that is what we call embolectomy, removal, no, ectomy, removal. So, transvenous catheter embolectomy. This is a technique in which a vacuum cup catheter is introduced transvenously into the affected pulmonary. Okay? Then another one is the interrupting the vena cava. This approach prevents the sludge or thrombi from being swept into the lungs while allowing adequate blood flow. So these are our surgery, no? Surgical intervention. What are our nursing responsibilities, no? If that is the management, what is our nursing responsibilities? Okay, wait lang, kaya marag punot na out kores. So what we are gonna do is we have to monitor the coagulation studies. Kaya remember, we are giving anticoagulant. Basing masobraan, ma-overdose, no? Delikado po. And report to the physician if there is any unusualities. Anticoagulant therapy may be adjusted as often as every 6 hours based on the laboratory results. So often yun, perminti kuha og laboratory test to check also if the therapy is effective. Then, protect the patient from injury so that excessive bleeding does not occur. Pag mga naka-anticoagulant class, no, dito nyo malabas na kailangan, hindi sila pwede matusok, dili sila pwede mag-hold og mga objects na pwede sila masaman, or mag-toothbrush, aggressive toothbrush, kay magka-gum bleeding, mga anak. Okay? Pwede magdugo-dugo ilang baba. And then, dili sila pwede mag-pick sa ilang nose, mangugmo, dili pwede class ha, pick of nosing, muna siya ang English, speaking of nose, sa mangugmo. Dili sila pwede, kaya pwede mag-bleed, no, mag-nose bleed sila. Teach the patient to use a soft toothbrush and electric razor to prevent injury. So kaya, yan, all part of our nursing intervention. Malabas ito sa board exam, no? If your patient is on anticoagulant, anong gagawin mo, no? Option. No, tas tagaan mo answer na mali. Or sometimes, tanan tama is, tama ang option, pero naay palibak. So always remember, soft toothbrush, soft bristled toothbrush. Okay? And then, electric razor. Dili ka tong sharp razor, nakatong sa tag-G's lang, makita niyo sa tindahan. And then avoid IM injections. IM injection can result to hematoma in an anticoagulant patient. Instruct the patient to report any signs of bleeding such as hematuria or easy bruising. Okay? Kung may mga bunog-bunog, inform. Pag nag-ihi na si patient og dugo, inform. That is hematuria. Hema, blood, formation, blood in the urine. Okay? Next, bleeding may be associated with excessive prolonged clotting and may require a change in anticoagulant dosing or administration of antidote. So kung na-overdose sila, antidote na diretso. Okay? Pero kung kung dosing lang, i-adjust lang, i-decrease or increase. Okay, let's proceed with ARDS. Next disease is acute respiratory distress syndrome. What comes into your mind? Sumuka sa mga chorus, right? What comes into your mind when you say ARDS? Are you familiar with this? Hello? Wala? Kadug naman wala? Yes or no lang?
Kadungog
Di po
naman.
ako familiar. No daw. Sige. Okay. Rapid occurrence of difficulty of breathing. Pwede? Pero narinig na ma'am. Okay, sige. Tama, rapid breathing. Distress man ma'am. So, rapid breathing. Oh, very good analogy, no? When you say ARDS class, this is formation of fluid inside your alveoli. No? That is why inadequate of breathing naga-distress si patient. So let's proceed para makita ninyo ang picture. Okay. So ARDS closely resembles with severe pulmonary edema, results from increased permeability of the alveoli capillary membranes, and the acute phase of ARDS is marked by rapid onset of severe dyspnea that usually occurs less than 72 hours after precipitating event. If this is the normal alveoli, this is what it look like in the acute respiratory distress syndromes. There is a fluid formation inside your alveoli, and if there is fluid formation there, again, balik na naman tayo, paano yung carbon dioxide and oxygen carbon dioxide and oxygen exchange natin? Paano yung pag-recoil, expand, and pag-recoil ng ating alveoli if there is fluid inside? Okay. Later on, we will look how does it happen. Paano po nangyari yung fluid formation doon? Okay. But what are the cause of this? Etiology is sepsis, pneumonia, trauma, shock, narcotic overdose, nag-adik-adik, no? Inhalation of irritants or na siya nasimutan, no? Nag-inhale siya, nasunog. Naisunog siya ng balay, inhale niya itong smoke. That cause, pwede yan. Or burns. Pancreatitis is sometimes rare. Each of these causes begins a chain of events leading to alveolo-capillary damage, no? And non-cardiac pulmonary edema or pulmonary edema that is caused by heart failure. ARDS usually affects patients without a previous history of lung disease. So, kalit lang, no? Some of it. What are the clinical manifestations? No? Yan. Initially, the patient may experience dyspnea and an increase in respiratory rate or tachypnea. No? Respiratory alkalosis result from hyperventilation. Mamaya, pag mag-ABG, mamaya time pa tayo kung aabot tayo sa ABG, explain ko sa inyo bakit respiratory alkalosis ang result pag merong hyperventilation. Okay? Then, fine inspiration crackles may be auscultated. As the condition worsens, breathing becomes more rapid and labored, and the patient becomes cyanotic. The patient is no longer able to oxygenate the blood and get rid of the carbon dioxide, and respiratory acidosis happens. So, di ba? Paano sila ma-exchange lagi kung napuno na yung fluid yung alveoli? Oxygen therapy does not reverse the hypoxemia. Kahit mag-oxygen ka pa ng 6 liters, 10 liters, 15 liters, dyan, hindi ma-resolve yung hypoxia. Bakit nga? Kasi di ba sa alveoli yung problem? Next, complication that can result from ARDS includes heart failure, pneumothorax, related mechanical ventilation, infection, and disseminated intravascular coagulation. An ECG is done to that is the clinical manifestation. For the management, medical surgical management, we also again do ECG. Bakit nga? Di ba? Dyspnea, no? Tachypnea. We wanted to check if or differentiate, is it a lung problem? Is this a heart problem? Okay, di ba? Sa chest mo niya po na siya located. The patient with ARDS is cared for an intensive care unit, ICU good knee. No? Then treatment begins with oxygen therapy that is adjusted based on the repeated ABG. So there is a diagnostic test of ABG to check the oxygen saturation of your patient in the lungs or in the blood. Then intubation and mechanical ventilation are necessary in most cases with the use of PEEP or positive expiratory end pressure to keep the airways open. So diuretics may be used to reduce pulmonary edema because there's fluid sa alveoli, di ba? Sabi ko kanina, may fluid doon, sulod alveoli. To remove that, tanggalin natin ang fluid, di ba? Common sense. May fluid doon. Tanggalin natin yun. Paano tanggalin? Diuretics. Remove the fluid in the alveoli. Okay? Next, IV fluids are administered if blood pressure or urine output is low. Pulmonary artery catheter may be used to monitor hemodynamic status. If infection is underlying cause, antibiotics are administered. If sepsis, no, yun yung number 1, di ba? Pag ARDS na etiology, reasons, bakit nagkaka-fluid formation doon? If sepsis, antibiotics are administered. Okay? First, you have to identify what kind of bacteria or infection is there para mag-give mo yung proper antibiotics. Hindi man pwede na, hindi mo alam. Then, parenteral nutrition may be given to maintain nutritional status when the patient is acutely ill. Positioning the patient with less involved lung in a dependent position or good lung down allows the better lung to be well perfused with blood and may increase PaO2. Prone positioning has been also shown to increase oxygenation in patient with ARDS. So may mga study na ngayon, no, na ang best position daw is prone and at saka side lying. So let's proceed with what happens inside our alveoli. Uy, ano, di man yung legs. Ayun. Ay na sa kumbora. Okay. What happened is, this is your alveoli class. Diba? This is the, yan. This is one of our circulatory system, no? That is located in our lungs para dito mag-exchange, no, ang oxygen o carbon dioxide. So here, no, this is your alveoli. Diba nakabalok ang alveoli ng mga blood vessels natin. Ayan. If there is an injury or reduced normal blood flow to the lungs, allowing platelet to aggregate. This platelet release substances such as serotonin, bradykinin, and histamine that inflame and damage the alveolar membranes and later increase capillary permeability. So, kung kung ang cause nito is, depende kung anong cause, yung kanina sa etiology natin, sepsis ba, shock, or trauma. So, depende sa cause, ganito ang mangyari. There will be formation of platelet or platelet aggregation. So, platelet aggregation, if that happens, let's say, for example, class, i-erase ko ito, para makita ninyo yung drawing. Ayan. This is our, di ba, RBCs, di ba, sa blood, diba, nalingin atong RBCs. This is our platelet. Okay? There is a platelet aggregation that is happening here. Okay, kanina mga gagawin ng circle. This platelet aggregations releases serotonin, no, which is this S. That is our serotonin. The histamine, which is our H. And our bradykinin, which is our B. Okay, this production, no, inflame our alveoli, thus increasing the alveolar capillary permeability, no, decrease. So, ang permeable, di ba, ang permeability of your alveoli capillary mag-decrease. Let's proceed. Yan. So, histamines and other inflammatory substances increase the capillary permeability, fluid shift into the interstitial space. So, yung histamine, nag-take action siya, no? Ang nang-happen sa wall dito is nanay mga buslot-buslot. Okay? So, as you can see, no? There is pathway. Nanay mga buslot or nanay agianan para maka-transfer yung fluid from your blood vessels going to your alveoli. Okay? So, because of this histamine, no? This helps, because of this histamine, happens with the permeability, na-destroy niya yung permeability of your alveoli, capillary membrane, papasok na yung fluid, no, from your blood vessels to your alveoli. So as the capillary permeability increases, proteins and more fluid leak out, causing pulmonary edema. Kaya nagkakaroon ng fluid inside your alveoli. From here, no, papasok na siya, ganyan, dito sa mga buslot na na-create. Okay? And there will be fluid accumulation inside your alveoli. Okay. So, the fluid in the alveoli and decreased blood flow damage surfactants in the alveoli. Remember, your alveoli has a surfactant. Di ba? Na siya fluid surrounding that, no? Kaya para mag-recoil and ano siya, mag-recoil siya. That is your surfactant. Nag-help siya. Pero, what happened is to destroy siya. So, this reduces our alveoli's capacity to recoil. So, this reduces the alveoli cells' ability to produce more surfactant. Without surfactant, alveoli collapse and impairs the gas exchange. So, what did it look like? Ganito na, no? May water na nga, no? Meron pa nga aggregations, no? Ayan. And then there is a protein that is already inside because nakapasok na sila from your capillaries. Then the patient breathes faster, but sufficient oxygen can cross the alveoli capillary membrane because CO2, however, crosses more easily and is lost with every exhalation. Both oxygen and carbon dioxide levels in the blood decrease. So what happened here is, as you can see, instead, no, magpunta ang oxygen, papunta sa capillary system mo, to provide oxygen to your body, di ba? Papunta na ni sa circulatory system, no? Kaso lang, hindi na makapunta sa circulatory system mo yung oxygen. Bakit? There is fluid blocking there. Paano makapunta siya sa iyong capillary system or circulatory system? Because of that fluid formation. So, ang nakakalabas is yung carbon dioxide, no? Naa-out lang si carbon dioxide. Okay? Because carbon dioxide is very gaan. Magaan yung masyado. Lalabas yan siya. Okay? So here, that is also why, if hindi nakalabas si carbon dioxide, if ever, hindi makalabas, there is also a formation of carbon dioxide in the increased carbon dioxide in your blood. Ayaw mag-next. Yan. So what happened here is, as you can see, pulmonary edema worsens, meanwhile inflammation leads to fibrosis and which further impede gas exchange, resulting hypoxemia and leads to respiratory acidosis. Class, always remember, if there is increased CO2 in your blood or in your circulatory system, it can lead to acidosis. Kaya sinasabi ko, respiratory acidosis, usually ang result pag ganyan is carbon dioxide is considered acidotic. If that acidotic remains in your body, hindi lumalabas because of the fluid in your alveoli, nare-remain siya sa katawan. Kaya pagkuha ng ABG, pagkuha ng blood mo, pag run doon sa machine, respiratory acidosis ang result. Kasi your carbon dioxide again is acidotic. Kaya nare-result siya sa respiratory acidosis. Okay? Yan. What are our diagnostic tests for our ARDS? So, yun, nakuha ba yun, no? Paano nagka-fluid formation in the alveoli? Ayan. With the diagnostic test, we have ABG, pulmonary oximeter, pulmonary artery catheterization, and chest x-ray. For our management, we do ventilation, yung kaya kailangan i-admit talaga sa ICU class kasi hindi ito siya pwede sa ward lang, kailangan i-monitor ang oxygen saturation ni patient continuously. And kailangan i-intubate ang patient. When once they are intubated, kailangan po sila nakakonect sa mechanical ventilator. And that is one of your indications, kaya i-admit ang patient to ICU. So ventilations, medications such as opioid or neuromuscular medication and sedatives. Positioning, no, yung side lying and prone. Fluid restrictions, fluid restrict na tayo kasi common sense pag ARDS, di ba, may fluid sa lungs. Mag-inom ka pa na madaming tubig. Saan to? No? So ilumos pa ni mo sa mot, iyang lungs, di ba? Common sense will tell you, ay, may fluid na sa lungs. Ilasan siguro natin ang yung water, excessive water sa body sa patient. So kaya i-restrict. Nutritional support to help the patient, no, acid-base balance correction with the help of your ABG result. So kung acidotic, magbigay ng mga basic na magamot para ma-normalize. Pag basic or alkalotic, magbigay ng mga gamot para mag-normalize. Okay? Next. Ayaw mag-next. Ayan. So, what are you gonna do with your nursing responsibilities with ARDS? You have to record your INO. Ma'am, hanggang diri INO, yes, di ba? But again, no, there is excessive fluid accumulation in the lungs of your patient. So, you have to monitor. INO. Monitor for signs of renal insufficiency or failure, decreases in urine output less than 30 ml, and monitor the BUN and creatinine. Check mo din yung kidneys, no? Kasi baka nag-decrease na ang kanya ihi. No? Monitor for possible fluid overload if ever there is, kasi mas nalumos na nga yung lungs, no? Yung alveoli, dagdagan mo pa, no? Overload, sobra pa. So more fluid going in than coming out, patient may end in heart failure, compounding the fluid building up in the lungs. Weigh the patient daily. Inability to handle excess fluid, cause third spacing of fluid into the interstitial spaces, and increasing the weight and causing edema. So edema is, di ba, fluid formulation in your interstitial. So nasa skin, no? Pag anan mo mulubong, yung kamot. So when do we weigh our patient? When? Buntag, udto, gabi, yung panihapon, unsa man, kami man. Sorry. Sada before meal. Unsa na meal? Breakfast, lunch, morning, very good. Okay, I see answers. Thank you so much, God. I see answers in the chat box. Very good, no? Pero dili sila sure kin ay daghang question mark. Nag-answer na lang daghang question mark. 5 ka buo. So dili sure. But don't worry, you're correct. The correct answer is morning. Early morning. Di lang pa di morning. Kaya naman po morning. Morning pa man ang alas 10, di ba? Alas 9, morning pa man na. Usually, we weigh our patient early in the morning. Pag mata niya, first thing in the morning, timbangon dayon. Okay? Ay, sa pakaon na. No? Kaya basig ni kaon siya, di nagkaon siya isa ka lechon. So, bugat siya sa mot. Dili to siya fluid imong ginatimbang. Ang lechon imong ginatimbang. No? So, before siya mag-eat, first thing in the morning, pag naog pa lang niya, no? Timbangon. Okay? Wala pa siya nakawiwi, timbangon. Okay? Then change position at least every 2 hours to prevent pressure build-up and skin breakdown or ulcers. No? Avoid overexerting the patients during treatment. Patient will tire easily and will have problems with increased oxygen demands and also provide rest periods during activities. Explain to the patient that the importance of doing coughing and deep breathing exercise after coming off from ventilatory. The patient needs to move adequate air in and out of the lungs. Coughing helps to rid the lungs of any remaining fluid. This is what they call extubation. What is extubation? This is where the removal of your ET or endotracheal tube to your patient. That is your extubation. Gitanggal ang tubo sa baba. Kaya diba, gi-intubate siya. Kaya kailangan na natin intubate ng mga ARDS na to. Okay, gi-intubate siya. Kung na-okay na siya, medyo kaya na sa iyong lungs, ma-assess na nila sa katong capnography. Kita nila dito ang pag-inhale, exhale. So kung okay na siya, i-remove na ng tubo. Hindi naman na pwede forever. No? Walay forever, pati sa tubes. No? Tanggalan ng tubo, and then i-practice siya na mag-inhale, exhale siya on his own. And then i-encourage ang coughing. Kaya para makaya sa iyang lungs, mag-expectorate atong mga fluids or mga phlegma na nasulod sa iyang lungs. Okay? Then, how to identify the signs of respiratory distress? Any signs that symptoms may be returning, such as shortness of breath, coughing, wheezing, rapid breathing, cyanosis, restlessness, or anxiety. So, those are some of the symptoms also. Okay. Pahaba. Tagala. Uy, wait lang. Tapos pa kayo. Okay, let's proceed with respiratory failure. Kapoy na ko storya. Respiratory failure. Ayan. This is what we call respiratory failure. This is a sudden, life-threatening, another life-threatening, yes, life-threatening deterioration of the gas exchange function of the lungs and indicates failure of the lungs to provide adequate oxygen or ventilation for the blood. What is our clinical manifestation? The patient with impeding respiratory failure may become restless, confused, agitated, or sleepy. Tanawan niyo ang picture sa upper right side. So, nakita niyo yung lalaki, naka-X iyang lungs. No? Bakit ko gi-X yan? Kasi pag sinabi mong respiratory failure, anong papasok sa utak mo? Failure. No? Fail. Hindi niya ginawa ang kanyang job. Ang job ni lungs is to do gas exchange. So, hindi niya ginawa, that's why gi-X ko ang lungs niya. Kaya when you say respiratory failure, come to your mind, this is the deterioration of the gas exchange function of the lungs. Hindi, yes, very good. Hindi nag-function well ang lungs niya. Hindi niya ginawa ang job niya to do gas exchange. No? Very good. May nakita ko ang nag-answer sa chat box ng correct. Sino ito? Very good. No? Yan. Clinical manifestation. The patient is pwedeng, ito yung mga manote mo sa patient. Restlessness, confused, agitated, and sleepy. So, ma'am, ano sleepy man? Katulugon din, ma'am. Ay, class, ingani na explanation. Di ba your respiratory or your lungs? Yes. Uy, pag ko ma-explain tagani ko na answer, no? Wait lang. Ma-answer sa ko, ay ma-explain sa ko kay some of you do not know. Patients become sleepy because, no, the lungs is inadequate to do the gas exchange. So, pag hindi niya nagawa, there will be decreased oxygenation in your body. Okay? Pag decrease ang oxygenation in the body, might as well decrease din yung oxygen na pupunta sa mga cells. Pag decrease yung oxygenation pumunta sa cells, hindi sila mag-function. And part of it is your brain. Okay. If your brain is receiving decreased O2, they will be having episodes of sleepiness. Okay? Kaya kayo, kung antok na kayo na nakikinig sa akin, anong gagawin? Deep breathing. Kaya sabi mo, ma'am, decreased oxygen. Kaya basig na ay nasa oxygen supply mo adto sa imuhong utok, no? Ayan. Deep breathing lang, no? Ma'am, kailangan ako mag-oxygen. Not necessarily, no? And other than that is sleepiness is maybe cause also hypoglycemic, no? Gama wala kay kaon-kaon. So wala glucose na supply sa imong cells or wala na ATPs ba na ma-convert. So kung wala kang kaon-kaon, wala kang kinakain or kulang ka ng ATPs, paano mag-function yung brain mo? Okay? So kaya kain-kain din pag may time kasi sometimes pag mag-RLE ko, pag sisudan ninyo question, mag-attendance sa sisudan ka ganyan ang lunch. Wala pa kung kaon, ma'am. Wala pa may nagluto, ma'am. Ano mga answer? Ano di mo mangaon? Mangaon mo, kaya it will provide, no? Glucose to your brain. Next, early signs are those associated with impaired oxygenation and may include restlessness, fatigue, headache, dyspnea, air hunger, tachycardia, and increased blood pressure. Increased blood pressure is compensatory mechanism, class, no? Kasi feeling ng body mo in order to adequately provide oxygenation sa body because the lungs is inadequate to do it, the body will try to compensate. Okay? Your body will to increase the pressure para mag-increase ang pump, mag-increase ang pag-travel sa blood para tingin nila mag-increase ang oxygenation or delivery. Okay? That's a compensatory mechanism. Then hypoxemia progresses, more obvious signs may be present, including confusion, lethargy, tachycardia, tachypnea, central cyanosis, diaphoresis, and finally, respiratory arrest. There will be also a presence of accessory muscle. Use of accessory muscles. Pag maginhawa ang patient mo, kay gamit na niya ang kanyang tibok chest. Anak na. Kasi di ba the lungs is uneducated to do it to function properly. Okay? Nag-fail na ang lungs mo. So, gamit na, in order to mag-expand siya, use of accessory muscle to expand properly. Kasi thinking niya, pag mag-expand siya, no, mas madaming oxygen ang magawa niya. Pero, the lungs is already, no, malfunctioning. Okay? Next, arterial blood gas cells shows the decreasing PaO2 and pH and increasing PaCO2, which lead to respiratory acidosis. The patient is cyanotic and dyspneic, and respiratory rate becomes rapid and deep in effort to blow off excess carbon dioxide. So, the ventilation or perfusion mechanism of a impaired lung, and so next, yan. Here are our ventilatory failure mechanism. Okay? For this one, it is the impaired function of the central nervous system, no? Hindi yung central nervous system mo para maginhawa ang lungs mo. Muna si brain, huy. Pagliyok na, pagtrabaho na lungs, no? Bakit kaya ganun? There's an impaired there because nag-adik-adik ang patient, nag-overdose. Another one is head trauma, no? Nabangga ang patient, bugs, igo ang ulo, no? Apektado ang central nervous system. Hindi na nakaprovide ng impulse papunta sa lungs to breathe. Okay? Non-infection, no? Na-infect ang brain mo, no? Kasi causing no inadequate impulse to tell the lungs na, uy, ginawa na. Okay? Or sleep apnea, no? Yung breathing sa ating brain, no, na nagsasabi na, oh, you breathe na. Okay? Next, another ventilatory failure mechanism is the neuromuscular dysfunction. Pag sinabing neuromuscular, ito yung from the neurons of your brain to your muscles. Okay? So ano yung mga problems with that? Ito yung myasthenia gravis, Guillain-Barré syndrome, amyotrophic lateral sclerosis, and spinal cord trauma. Kaning MG and Guillain-Barré syndromes, mag-classmate ni sila, no? Di yung classmate, magkapamilya, no? Same na silang effect, no? That there is weakness na nafe-feel sa patient. Okay? So pag myasthenia gravis and Guillain-Barré syndrome, there is a weakness that is signs of symptom of your patient. So if there is weakness, part of it is or weakness of your muscles, no? Part of it is your lungs. Okay? Next is spinal cord trauma. O like for example, no, nabanggaan ka. Pagbangga si mo, nahiwi mo ang C3. 'Di ba? Diri sa may sa may spinal cord mo, C3, diri banda sa likod, no? Because of that, no, inadequate na din ang neurons or nerves na naka-provide doon. So maipit din yun siya, okay? Causing, no, the muscles on that area to inadequately function. 'Di ba class, pag maigo ay muhang diri kana sa Before Me na movie, 'di ba? Kita mo ana, Me Before You, no, na diri ang naigo saya sa liog banda, cervical spine, no? Cervical, C2, diri lang or C3, diri kutob. Below your legs, ay below your neck, dili na muliho. Okay? So no muscular function. If there's no muscular function, your lungs is also inadequate to function well. Kasi wala na masyado, naipit na yung nerves na naka-provide ng ano doon, ng impulse. Okay? Next, musculoskeletal dysfunction. No? Muscles and skeletal. So, example of that is the chest trauma, kyphoscoliosis, and malnutrition. No? Ayan. Chest trauma, nabanggaan sa chest. Naigo sa manibela. So, paano yun mag-function ng well? Inadequate na, no? Then, pulmonary dysfunction such as COPD, asthma, and cystic fibrosis. These are kuan ha kanang lala na cases na ha, hindi yung early stage. Okay? Next, another causes of our respiratory failure in terms of oxygenation. There's a failure in oxygenation is the pneumonia, the ARDS, heart failure, COPD, pulmonary embolism, and restricted lung disease that causes decrease in lung volumes. These cases, no, in extreme, no, or wala na treat, no, this can lead to respiratory failure. Mag-fail na talaga ang lungs. Hindi na sa function. So, balikan natin itong ARDS kaganina. Di ba? Fluid accumulation in your alveoli, no? So, hindi na siya na-treat, maglala, no? Your lungs will collapse, no? Hindi na siya mag-function. Kaya nag-lead ng respiratory failure. Okay? Kani sila tanan. In a worst case scenario na. Okay? Next, your medical surgical management. So there are two cases ha, the ventilatory and oxygen mechanisms na nag-fail, kaya nag-lead ng respiratory failure. Yan, medical surgical management. Here. Carefully assess the patient, report significant findings to the physician immediately. If there's abnormal mga assessment niyo, you inform the doctor. It is easy to mistakenly treat symptoms of agitation or confusion with sedatives, which will speed the onset of respiratory failure. Bakit pala, pag mag-give tayo ng, di ba, meron yung restlessness sa signs and symptoms or clinical manifestation doon. Then, gusto mo i-sedate ang patient kapag dili siya mag-restless. Sedative can also decrease the RR of your patient. So, kung masobra ka-give ng sedatives, no, mag-decrease ang RR, kaya pwede din mag-lead to respiratory failure. So, i-check mo din. Okay? Next, oxygen therapy via nasal cannula or mask is provided. If the patient has chronically high PCO2, oxygen is administered at a flow rate of 1 to 2 liters per minute to prevent interference with the hypoxic drive. No? Antibiotics are also, or other treatments are ordered to correct the underlying cause of the failure. So, before class, hindi immediately mag-respiratory failure agad. Okay? Napa na siya, sakit prior to that sakit prior leading to that or napay cause, no? Like for example, katong mga gipang mention natin, either the mechanical or oxygen failure, either doon, because of that, nag-lead siya respiratory failure. Okay? So hindi respiratory failure agad. Okay? Yan. So kailangan mo na i-identify ano yung cause and then you treat that. Okay? In order for you to prevent the further occurrence of the respiratory failure. Next, bronchodilators. This promote ventilation and secretion removal. Patient is instructed to cough and breathe if able. Suctioning is indicated if the patient is unable to cough effectively. And mechanical ventilation via endotracheal tube or non-invasive positive pressure ventilation may be required. Intubate si patient kung kailangan na yun. Then before invasive ventilation is initiated, it is important to check the patient's advance directive. Kanang advance directive class kung nag-consent ba siya, no? Nagtubuhan siya or dili. Okay? Yan. Your nursing responsibilities of a patient with respiratory failure. First, you have to assess the patient's degree of dyspnea on a scale of 0 to 10 if the patient is able to participate. Check mo. Then, check the RR, the effort, and the use of accessory muscles. Then, monitor for the ABG and oxygen saturations. No? Check for the presence of cyanosis. Check for mental status, no, of the patient. If she is restless, confused, or decreased ang GCS niya or Glasgow Coma Scale or RLS. This will indicate there is a reduced oxygen that can produce central nervous system symptoms. Symptoms of underlying cause of respiratory. If the cause is infectious, sputum and amount of and color, temperature, and white blood cells counts are monitored. All assessment findings should be compared with earlier data, and even subtle changes in assessment findings can be significant and should be reported. So please do monitor parate. Okay? So that is your respiratory failure. Again, napay prior cause ha is either the mechanical and oxygenation failure that leads the patient of the lungs of the patient to fail. Ayaw niya mag-function or mag-gas exchange. Okay? Let's proceed with pneumonia. What comes into your mind with the sinabi pneumonia? This is an acute infection of the lung parenchyma that commonly appears or impairs the gas exchange. No? Inflammation of your alveoli, no? Because of bacteria. So, here, there are different causes. Karaming klaseng pneumonia class. Daghang klaseng pneumonia. Pag sinabi, uy, pneumonia man na siya. So, pag sinabing pneumonia, daghang klaseng pneumonia. Ano si cause sa pneumonia? Okay? So, we will discuss the different classification of pneumonia. So, pneumonia is caused by an infecting pathogen. It is bacterial or viral, or by chemical or other irritants such as aspirated material. So, depende, no? You will know what is the classification of the pneumonia of your patient if you can identify what is the pathogen. Okay? Bacterial caused ba ito? Viral caused ba ito? Or aspiration caused ba ito? So, here are the classification of your pneumonia. We have the CAP, HAP, HCAP, VAP, and aspiration. So, first, let's talk about ayaw pang mag-next. Ayan. Ang lag. Madungo pa ko ninyo, class.
Opo,
Yes,
ma'am.
ma'am.
Sige, thank you. Marag, nalibog ko kung akong internet or ano, kailangan na siguro kong mag-delete o paan, dagan na kayo og kuan sa computer. So, yeah, this one is CAP. Ano yung pneumonia? Pneumonia siya, CAP. This is community-acquired pneumonia. From the word itself, community-acquired pneumonia. Asan niya nakuha? Sa community. No? So, it occurs in the community settings, no? Less than 48 hours of admission. Then, hospitalization depends on the severity and what is the causative agent. If it's S. pneumoniae, H. influenzae, or pneumoniae, H. pneumoniae. So, depende ano yung cause. Okay, so, kaya kailangan i-sputum culture ang mga patient na ginapneumonia. I-check ang phlegma kung unsa itong naa dito, nakita nila dito. Okay, so, for S. pneumoniae, it is a 60-year-old marker. For H. influenzae, usually common in older adults. And N. pneumoniae, ang mode of contact nito or transmission is the contact of droplets. Kaya, big no-no talaga yung mag-ubo na, dili mag-cover of mouth. Walay cough etiquette. No? Sa imong tubangan, no? Bad na siya, okay? Lalo na ngayon na meron tayong COVID. We know already how to do cough etiquette. Okay? So, yan. Preliminary interstitial but may eventually result to bronchopneumonia. Viruses is common for infants and children, and this is an opportunistic virus, no? Kaya mabilis siya mag-spread. So, again, community-acquired pneumonia occurs in the community settings less than 48 hours. Okay? Next, let's proceed with ayaw lagi mag-next. Sorry, sobra na. Let's proceed with HAP, or the hospital-acquired pneumonia. So from the word itself, asa siya nakuha? Hospital. Okay? Acquired pneumonia, HAP. This occurs 48 hours or more after admission. Like for example, kung sa adlaw ron, 10-6. No? Nag-occur siya 48 hours or more after admission. So kung saan man ang ika 48 hours? 6, 7, 8. No? Pagka October 8, giubo siya. Pag-check, pneumonia. So, sa hospital, din niya nakuha ang pneumonia niya. Okay? Kaya hospital-acquired pneumonia. So, again, you have to take note when is the occurrence. And then, you have to take note how many days from admission siya nag-occur. Kung pneumonia na siya daan before gisulod, so dito siya hospital-acquired pneumonia. Na naman siya pneumonia daan before siya sa gawas. Pero kung na-admit siya, okay pa siya, kasi ubo-ubo, pero nag-stay siya dito 1 week, sa ikaduha na adlaw, ikatulong na adlaw, nag-ubo-ubo siya, that's what you call hospital-acquired pneumonia. Gets? Sa hospital niya nakuha. Wala siya nag-ubo-ubo prior to admission. Dito na siya nag-ubo-ubo na siya sa hospital. Okay? So, exposure to potential bacteria from other source or intervention-related factors or overuse and misuse of antimicrobial agents. So, like for example, class, no? Si patient, lahi ang problem sa intubation. Like for example, ang cause of intubation is the ARDS. Na siya ARDS, di ba? No, kailangan i-intubate, no? To assist the patient to breathe, di ba? Ito yung sura natin kanina. Unya, na-admit sa 10-6. Pag run sa test, sputum culture, wala pa yung bacteria, wala pa yung nakita, no? Pero pagka 2 days after, nagtingala ka, increase na ang sputum production, na kayo madungog ng mga crackles, no? And that is because, no, na-acquire na yun, na-expose siya of that bacteria. Okay? It's sometimes exposure to procedures such as suctioning, no? Kaya naka-intubate man si patient, no? Yung tubo, no, na-expose doon. So pwede ganon. Okay? Another one is healthcare associated pneumonia or HCAP, no? So from the word kakinsa gikan kay healthcare, no? Kay nurse, kay aide, no? Isa naka-duty dito, sala sa nurse na naman. Sa kasalanan na naman natin. 'Yon, no? So because hindi ka nag-practice ng hand washing, no? Proper hand washing ng patient. Kaya nadadala niyo yung pneumonia sa kabilang patient, droplets, nahawakan yung patient, umuubo si patient, nagsuction ka sa pikas nga na pneumonia, tapos ibalin ka sa pikas sa patient, nagsuction na buka dito. So na-expose na yung patient sa pneumonia na yung gidala sa from other patient. That is why when you take care of patients, from one patient, you wash hand and then go to your another patient. Okay, so that is healthcare-associated pneumonia. Pneumonia occurring in a non-hospitalized patient with intensive healthcare no content one or more of the following. So hospitalization greater than 2 days in acute care facility within 90 days of infection. This is common, no, sa mga residential, kanang mga geriatric na to ng mga patients, kanang mga yana. Okay? Kanang mga therapy patients natin, na mga infusion units, na moadto lang sila dito para magpa-infusion or mag-chemotherapy, and then muli na po sila after. Okay? So, yan. Antibiotic therapy, chemotherapy, or wound care within 30 days of current infection. Hemodialysis treatment at the hospital or clinic, home infusion therapy or home wound care, and family members with infection due to multi-drug-resistant bacteria. Do you know what is multi-drug-resistant bacteria?
Yes po. Hindi na effective yung drugs po, ma'am, for a certain bacteria.
Yeah, not drug. What drug?
Antibiotics, ma'am.
Yan, very good. Correct. Antibiotics. Si patient, sige inom antibiotic. Wala di mo humanon ang 7 days. Pag sinabi nito, 3 times for 7 days. Dili humanon. So, nag-elevate din ang degree of bacteria. Nag-evolve siya. Wala din yung human yung azithromycin na. Anak tong bacteria. So, gi-increase ang tambal to coamoxiclab. Medyo isog-isog na. Wala din inom sa pasyente ang coamoxiclab. So, nag-evolve ang bacteria. Kay ma-immune man siya. No? Nagiging drug resistant. No? Isog na kaayo. No? Grabe na kayo, mahal. The more naga-increase ang amount of your degree of your antibiotics or generation, na mga first gen, second gen, anak ba na, di ba? So, mas mahal siya. Okay, so, mas expensive siya. Mas luoy ang pasyente. So, kaya, increase one of your, sa patient, ma'am, humanagid na. Kaya masing ka ng tablet, mahal naman gani, mag 800, 500, ang isa ka tablet. No? 3 times a day, ang isa ka tablet 500. 500 times 3, 1.5 na, isa ka adlaw. Times 7. 1.5 times 7. So, 8,000. Dagan dara ing ana siya class ka mahal. You think na barato lang ang mga tambal? Sus, ginoo ko. Ang 10,000 class, isa lang naka-IV. Kana yung mga IV na mga antibiotics, mas mahal na. 1K. Pinakabarato, 1,2. Ano. Tapos 3 times a day for 7 days. Sometimes 14 days. Kung grabe ang iyang infection. Sometimes, dili lang pag isa ka antibiotic, duha pag yun. So, pag MRSA na. Na-teachings yun sa mga patient. So, balik na ta sa pneumonia. Asan ako? Wait lang. Ayun na mag-next. So, dito tayo sa ventilatory associated pneumonia. So, again, occurrence or kanino galing sa ventilator. A type of H or HAP that develops greater than or equal to 48 hours after endotracheal tube insertion. So, wala din pneumonia ang patient, pero pag tube sa iyahan, yung pneumonia siya, so that is VAP. Okay? So, the endotracheal tube gives the glottis and open so secretion can be aspirated to the lungs. Sometimes, no, exposure, mali ang pag-intubate ni doc, hugaw yung pag-intubate, or ang pag-suction sa nurse or staff, ganyan. Kaya nagkaka-ventilator assistant. Or hindi talaga ginasuction. Kaya nag-stay yung bacteria dito, thus developing pneumonia. Next, opportunistic pneumonia. So, opportunistic na mga bacteria natin dito. No, that it affects our immunocompromised patient. So, kaya opportunistic pneumonia sila. Sino clients with very poor immune system, such as our patients that who are having malnutrition, HIV or AIDS patients natin, these are immunocompromised patients, transplant client receiving steroids, and cancer clients. So, kaya class, no? Kaya mga HIV natin ng mga patient class, tapos ikapila, yun ko naka-encounter ng mga HIV, AIDS, no, mga bata pa. One of the, trust me when I say, no? One of the first symptoms to the client before yan mag-AIDS or HIV, cough. Cough, get ang perminti na nila complain. Ubo-ubo. Ubo-ubo lang complain. Tingnan lang ka HIV positive di ay. No? Because ang ginatira dyan sila is the opportunistic pneumonia. Kana, pneumonia lang kalit. Immunocompromised man sila. Kana lang ka ubo-ubo pag check HIV positive di ay. Best in check pa ka, no? Or careful yun. Blood, mga mag-touch sa blood sa patient. Or mga needle prick. Okay. Next, aspiration pneumonia is the entry of foreign substances into the lower airway. Most common is aspiration of the bacteria that normally resides in the upper airways and can occur both in community and hospital. And other sources are gastric contents, chemical contents, and irritating gases. So in short, any bacteria that should not be in your lungs that is located there is aspiration pneumonia. Okay. So clinical manifestation, it's fever, pleuritic pain, myalgia, rash, sputum production, increased tactile fremitus, no? Di ba? Natututa mo sa fractal fremitus, yan mo dito, consolidation. Marked takipnia, respiratory distress, blood-tinged sputum, loss of appetite, and orthopnea. So, diagnostic test is the chest x-ray, sputum GSCS. Ito na yung culture, no? Sputum culture para ma-identify mo what kind of bacteria. Bronchoscopy, i-check yung lungs, no? Itignan through camera, ipasok sa bibig. Okay? Pulse oximeter and ABG. Here are also some of our determination through sputum. Paano malalaman, ma'am? If ang patient is streptococcus, if pseudomonas, if Klebsiella, and anaerobic, no? Usually class, memorize na lang nimo, ay, pwede yung same uta ha, pero sometimes, no, kanang pseudo, medyo aslon ka ni, gisimot, din mo, ma'am, sa kadagandagan ako na pasyente na pseudo, kleb, kabalo na jud ka, ay, pseudo man siguro ni positive. Wala pa naabot ang x-ray. Mga si Ma'am Verla nyo, mapustahan na naman ang usahay, no? Girl, murag pseudo gid girl, kay aslom kayo ang plema. Mabawaan ninyo, ang amoy sa plema, when you suction, pag mag-suction kasi kami ng patient na mga intubated, naka-trach, no? Siyempre, maglagpot ang sahay, manlupad ang mga plema, naman yung episodes na, labo na trach, manlupad ang plema, nagligo na kag plema, careful gid mo, no? Labo na mag-suction. Masimutan na nimo siya, medyo aslom, murag pseudo ni. Kani kay kleb di siya, kay lahi ubaw. Basta, soon, kung gusto mo mag-ICU. Pero, mas ma-differentiate mo yan siya sa color. So, pag mga strep, medyo rusty color sputum. Pseudo, hemophilus, and pneumococcal, kani, green sputum. Pero dili ka na nakaklas, kasi ubo mo, di ba, pag ganang green, gani kayo, ubo ka, wala, pseudo na ni. Not only, sa ipa-culture siya, para sure. Okay? Yung pseudo na ko, nagsumbong-sumbong na kasi mo mama, no? Kaya na si Ma'am Karen, ma'am, no? So, to kung nakakaroon, ayaw sa, no? Ayaw sa pagpanik. Basta wala ka na-expose sa mga pseudo patient, no? Kamo, wala man dyan mo na-expose, kaya wala mo na hospital. Pero kung usually, if you're working in the hospital, ma-expose dyan mo, especially with the droplets. So, kana, high chances na kay pseudo. Pero kung wala ka na-expose, ayaw pag-conclude dahil, greenish ako, ananaan ba ninyo, dulaan pa ninyo, bata ka mo, dulaan pa ninyo ang plema, no? So, yan. Klebsiella, pag red current, jelly sputum, no? Pag karang ilang plema, good class, murag jelly, pag uyugon nimo, maganana po siya, mag-wiggle-wiggle siya, anak siya. No? Di po di mo gunitan ha. Ma'am anak ha ma'am, i-check. Nakabutang man siguro siya sa sputum container, no? Ana lang nimo ang container. Okay? Or makita na nimo kung mag-suction ka, no? Medyo mabilin man ang mga excess na mga lama-lama sa jelly sputum di siya. Okay? Yan. Next is anaerobic, is foul smelling or bad tasting sputum. O wala bu ko ningon natilawan nimo ang sputum sa imong sa imong patient ha. Masking sa jowa pa na nimo na dili mag-share og sputum. No? Plema. Ha, dili uboy mo uyab, ayaw jud na haluki kay pneumonia pug ka. Duha na mo. No, wala sa wala sa encounter ron kay giubo ka. Okay? Nurse baya mo no. So maging pod, knowledgeable ba? Droplet. No. No encounter sa. No kissing. Ana. For your medical management, for pharmacological therapy, so number 1, antibiotic, no? Determine the cause, what is the culture result, and give yung antibiotic doon. Then IV, then oral. So, usually for antibiotic, IV din na first, no? Lalo na pag admitted. Okay, pag admitted si patient, gina-IV na siya. Then, i-change na nila to PO or meds na. Pero kung mga nasa gawas, kanang check-up lang, paulion, that's PO. Okay? Increase oral intake para sa plema, nebulizer para mahuk ang plema, bronchodilator para mag-expand or mag-dilate ang bronchus, antipyretic if mag-fever due to the bacteria, supported treatment kung ano yung mga problema niya or signs and symptoms na nag-occur sa kanya, i-support mo or i-treat mo. Then, pulse oximeter for monitoring of the oxygen saturation. Might as well include the ABG, saturation of the blood. Endotracheal intubation and mechanical ventilator if there is a need. Okay? So, ganito yung nangyayari, no? Ayan, there is exposure to microorganisms, no, that reach the lower respiratory tract. Thus lead to inflammation of your inflammation reaction, thus producing more exudates or yung plema. Okay? Because of that exudate formation or production, nag-increase, no, there is an alteration of the perfusion and oxygenation, thus leading to pneumonia. If there's also inflammation plus, there will be production of your WBC. No, sabi ko kanina, di ba, kung mga bacteria cause, S. pneumoniae, H. influenzae, katong mga cause, no, there will be increase in WBC, no, and production of WBC in the alveoli. So, Because of that, there will be perfusion and oxygen alteration, thus leading to pneumonia. But there will be also, again, exposure to those microorganisms, mag-increase ang sputum production, thus leading to, again, alteration in the perfusion and oxygen, thus leading to pneumonia. Okay? So your nursing responsibilities for these patients is, uy, Lord, isang oras. Nursing responsibilities. Administer oxygen if needed or prescribed. Monitor for labored respiration, cyanosis, and cold clammy skin. Encourage coughing and deep breathing exercise, and use of incentive spirometer. Place the patient in a semi-Fowler's position to facilitate breathing and lung expansion. Kung dili jud makaya, pwede ka high Fowler's, okay? And then change the client's position frequently and ambulate as tolerated to mobilize secretions and provide CPT. Ito yung chest physiotherapy. Sulat niyo dyan, CPT is chest physiotherapy. Katong itaktak ang plema, malusen. Itong, bakit tayo nag-change ng position? Kaya sa ICU class, no, ang mga patient natin, no, we do turn to side skew 2. No? Kasi para dili mag-stasis ang plema on the back of your patient. So igalaw-galaw din ang patient. Monitor pulse oximeter, monitor and record color consistency, and amount of sputum, provide a high calorie, high protein diet with small frequent meals, encourage fluid up to 3 liters per day to thin secretions unless contraindicated. Kung check mo din ha, baka merong ano si patient, congestion, okay? Kasi painom ka madami water, tapos congested parang patient mo, so times 2 na ang fluid sa body niya. Okay? Administer antibiotic as prescribed, administer antipyretic, bronchodilators, cough suppressant, mucolytic agent, and expectorant as prescribed. Prevent the spread of infection by hand washing and the proper disposal of secretions. Notify the healthcare provider if chills, fever, dyspnea, and pneumatosis or increased fatigue occurs. To receive pneumococcal vaccine as recommended by the healthcare provider. Okay? So ito, pneumococcal, uso na ito, di ba, nagapa-inject na ng pneumococcal vaccines ang mga tao karon. Before, di ba, before pa tong nagawas ang mga vaccine sa ating COVID, pneumococcal vaccines ang gina-inject. Okay? Okay. Ayan. So, plus, wala ko na human. Hindi ka po ako. Alas 6 na.
Okay, is there any question with the previous topic? So, I'll still have to continue. Tapusin ko lang ang respite class so that on the next meeting, neuro na tayo because we still short remaining time before the exam. Okay, so let's continue with the topics about COVID-19 and different respiratory problems. So, is there any question or clarification with the previous topic? If you have, can you type halang ha? Hold on mo na. So, we'll proceed with the next topic about the COVID-19, MERS-CoV, and our SARS diseases, no? So, I think you're already familiar with this kind of diseases. So, at least let's just have recap, no?
Disease, no? Coronavirus is an infectious disease caused by a newly discovered coronavirus called SARS-CoV-2. First learned this virus on December 31, 2019, following a report of a cluster of viral pneumonia in Wuhan, in People's Republic of China. There are many variants. Kulang ito class, no? Na ang sulat ka lang si BA2, 12.1, and the BA.2. Meron pa tayong Omicron. Madami tayong variants, no? Next, hindi ko na additional yung iba, but i-add ko lang on our next meeting. Next, the clinical manifestation. The most common symptoms of COVID-19 is fever, dry cough, and fatigue. Other symptoms that are less common is loss of taste or smell, nasal congestion, conjunctivitis, also known as red eyes, sore throat, headache, muscle or joint pain, different types of skin rash, nausea or vomiting, diarrhea, or diarrhea, chills, or dizziness. That's other symptoms. For the severe symptoms of COVID-19 include shortness of breath, loss of appetite, confusion, persistent pain or pressure in the chest, high temperature or high fever above 38 degrees Celsius. Other less common symptoms are irritability, confusion, reduced consciousness, anxiety, depression, sleep disorders, More severe and rare neurological complications such as stroke, brain inflammation, delirium, and nerve damage. So if ever experience ng ganito, please do seek medical care immediately. If possible, call your healthcare provider or your doctors or clinic nearest to your house or home. Call. Yan, kasi marami na tayong mga telehealth. So, which symptoms should you watch for? Ito, fever, chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. Diarrhea. How long after COVID exposure could symptoms start? So, symptoms can appear anywhere from 2 to 14 days after sometimes is exposed to the virus. But the guidelines state those who were exposed should watch for symptoms at least 10 days after the last contact with someone who had COVID. Anyone with symptoms should get tested. So again, if ever exposed to the patient, symptoms usually appears 2 to 14 days, no, upon exposure to the virus. For the guidelines, if na-expose ka, you have to wait until 10 days, no, from the last contact with that person na COVID. So anyone with symptoms always should be tested. Wait lang, painom water ha. Excuse me. A person with COVID-19 is considered infectious starting 2 days before they develop symptoms or 2 days before the date of their positive test if they do not have symptoms. This is according to the CDC. So, regardless of symptoms, those who test positive are advised to take specific precaution for at least 10 days. So, yun. You have to follow. So when should you get a COVID test? So regardless of the symptoms or vaccination, those who are exposed to someone with coronavirus should get tested at least 5 days after the exposure. Okay. So those who develop symptoms should get tested as symptoms develop. But if a test is negative and symptom persists, another test might be needed a few days later, particularly for those who use at-home test kits. Eh baka masyadong early kaya nag-early siya nag-test, hindi nag-reflect na positive. Pero later on, pag-test ulit, nag-positive na si patient. Okay? Diagnostic tests can show if you have an active COVID-19 infection and need to take steps to quarantine or isolation yourself from others. The molecular and antigen tests are the types of diagnostic tests that can detect if you had an active COVID-19 infection. Again, the molecular and antigen tests are used to detect if you have an active, present active COVID-19 infection. Samples for diagnostic tests are typically collected with a nasal or throat swab or saliva collected by spitting in the tube. For the antibody test, this antibody test looks for antibodies in your immune system produced in response to SARS-CoV-2, the virus that causes COVID-19. So, check if meron ng antibodies. So, antibodies test should not be used to diagnose an active COVID-19. Again, they should not be used to diagnose an active COVID-19 infection. Antibodies can take several days or weeks to develop after you have infection and may stay in your blood for several weeks or more after recovery. So, samples for antibody tests are typically blood from fingers pricked or blood drawn by your doctor or other medical personnel. So, here are the tests that are usually done for COVID-19. Let's look first for our molecular test. Molecular test is the diagnostic test. The viral, this is where you can say that the patient or the person has COVID-19. Molecular test, mga diagnostic test natin. So, we have the RT-PCR test, the LAMP test, and the NAT, or nucleic acid amplification test. So, this is taken nasal swab, either shallow or deep, on saliva. How long does it take to get result? Is less than an hour. At-home test and some point of care location, same day or 1 to 3 days, and some lab processing, 1 to 3 days, or some tests may take longer. So is there another test needed? Not usually. This type of test is typically highly accurate and usually does not need to be repeated. Some may indicate the need to retest in certain circumstances. So what it shows, this shows the diagnosis of active COVID-19 infection. Then what it can't do, so this test cannot show if you had or if ever you had COVID-19 or were infected with the virus caused in the past, so in the previous. Let's proceed with the antigen test. This is also our diagnostic test for COVID-19, viral test and a rapid test. This is taken by a nasal and nasopharyngeal swab. So some may be very fast for its result, and it depends on the test. So, is another test needed? Maybe. So, positive result are usually highly accurate, but false positive can happen in antigen tests. So, especially in areas where very few people have the virus. Negative results may need to be confirmed with a molecular test. So, very common na we hear natin is yung RT-PCR. Okay? What it shows. So, for the antigen test, it shows the diagnosis of active COVID-19 infection, what it can't do. It may not detect an early COVID-19 infection. Your healthcare provider may order a molecular test if your antigen test shows a negative result, but you have a symptoms of COVID-19. So it also cannot show if you ever had COVID-19 or where or in the past. Then lastly, the antibody test, also known as serological test, serology, blood test, and serology test. This is taken, a sample taken from the blood or finger stick or the vein. So how long does it take to get result? We may have the result same day or 1 to 3 days in some institution. So this test is another test needed for this. Sometimes a second antibody test is needed for accurate result. So what does antibody test shows? Shows if you've been infected with a virus that causes COVID-19 in the past. So what it can do? So it cannot diagnose COVID-19 at the time of the test or show that you do not have COVID-19. So that is for the antibody test. Here is the 2022 recommendation for people with COVID-19. So I think this was updated by May. This is 2022, May and CDC. According to the CDC, so isolate, stay at home for 5 days. Stay at home to keep others safe. Wear a mask. If you can't wear a mask, stay at home and away to class from people for 10 days. Stay in a separate room and use separate bathrooms if you can. Do not travel for 10 days. To calculate the recommended time frames, day zero is a day, ito na yung ano class ha, yung parang summary. Mahaba pa kasi nito. Yung isolation quarantine, mamaya i-present ko pa rin, but summary ito siya ha. So, baka magtaka kayo balik-balik. But yes, this is very common. Alam na natin to kasi usually ginagawa natin ito. Okay? So, again, do not travel for 10 days. To calculate the recommended time frames, day zero is the day you were tested if you don't have symptoms or the date your symptoms started. So, contact your healthcare provider to discuss your test result and available treatment options. Watch for symptoms, especially fever. If you have emergency warning signs, such as trouble breathing or persistent chest pain or pressure, please do seek medical care immediately. Day 6, no? Because diba, sabi isolate, stay at home for day 5. Pagka day 6, you have to do a do self-check. You have to check how are you feeling. You could have lost your taste or smell for a week or months after you feel better. The symptoms should not delay end of isolation. So, pwede pa rin mag-end ang isolation if ever meron ka ng presence of this one. So if no symptoms or symptoms improving, no fever without fever reducing medication for 24 hours, you can leave the isolation. But keep wearing masks around other people at home and in public for 5 days or 6 to 10 days. But if symptoms not improving or still have fever, continue to stay home until 24 hours after your fever stops without using fever reducing medications and your symptoms have improved. After you feel completely better, keep wearing masks around people at home in the public throughout day 10. Here, let's proceed with the quarantine. No? So if you come, what we're gonna do, if you come close in contact with someone with COVID-19, you should quarantine if you are not up to date on COVID-19 vaccine or are unvaccinated. These are for people who are unvaccinated or hindi updated ang kanilang vaccination. For this individual, the CDC and the IDPH recommends you to do the following. Stay at home and away from people for at least 5 days, day 0 to day 5. Excuse me. Yeah, day 0 to day 5. After your last contact with the person who has COVID-19. The date of your exposure is considered day 0. Then, wear a well-fitting mask when around others at home if possible. So, kailangan mag-mask kahit nasa bahay. For 10 days after your last contact with someone with COVID-19, watch for a fever. So, 100.4 degrees Fahrenheit or greater. Cough, shortness of breath, or other COVID-19 symptoms. If you develop symptoms, get tested immediately and isolate until you receive your test result. If you test positive, follow isolation recommendation. Mamaya we'll discuss with the isolation. Let's focus first in the quarantine. If you do not develop symptoms, get tested at least 5 days after your last contact with someone with COVID-19. If you test negative, you can leave your home but continue to wear a well-fitting mask when around others and home. And in public, until 10 days after your last close contact with someone with COVID-19. If you test positive, you should isolate for at least 5 days from the date of your positive test. If you do not have symptoms, if you develop COVID-19 symptoms, isolate at least 5 days from the date your symptom began. And then the date symptom started is day 0. Again, the date symptom started is day 0. You have to follow recommendation in the isolation section mamaya below sa ating discussion. If you are unable to get a test 5 days after your last contact with someone with COVID-19, you can leave your home after 5 days if you do not have been without COVID symptoms throughout the 5-day period. If wala ka na feel, walang symptoms, pwede na ka, no? Maggawas. But you have to wear a well-fitting mask for 10 days after your date or last contact when around others at home and in public. Avoid people who have weak immune system or are most likely to get very sick from COVID-19 and nursing homes and other high-risk settings until after at least 10 days. So if possible, stay away from people you live with, especially people who are high risk for getting very sick for COVID-19, as well as other outside your home throughout the full 10 days after your last contact with someone with COVID-19. If you're unable to quarantine, you should wear a well-fitting mask for 10 days when around others at home and in public. If you're unable to wear a mask when around others, you should continue quarantine for 10 days. Avoid people who have weakened immune system or are more likely to get very sick from COVID-19 and nursing homes and other high-risk settings until after at least 10 days. Do not travel during the 5-day quarantine period. You have to get tested at least 5 days after your last contact and make sure your test result is negative and you remain without symptoms before traveling. If you don't get tested, delay travel until 10 days after your last contact with a person with COVID-19. So, i-delay mo yung travel mo. If you must travel before the 10 days are completed, wear a well-fitting mask when you're around others for the entire duration of travel during the 10 days. If you're unable to wear a mask, you should not travel during the 10 days. Do not go to places where you're unable to wear a mask, such as restaurants, some gyms. Avoid eating around others at home and at work until after the 10 days, after your last contact with someone with COVID-19. Those who are close contact of someone with COVID-19 but are up to date on their vaccinations or have or had confirmed case of COVID-19 within the last 90 days do not need quarantine. But the CDC does recommend they wear a well-fitting mask around others for 10 days after their most recent exposure and get tested after at least 5 days. Let's proceed to the isolation. So the people who are positive for COVID-19 should stay home until it's safe for them to be around others, including even other members of their home. Health official recommended a sick room or area for those who are infected and separate bathroom if possible. So remember niyo yung panahon na mga ganyan, na mag-rounds ng taga-barangay para lang mag-check kung may CR ba yung kwarto. Yan. Then, magpa-picture pa yan sila. Picturean nyo po yung bahay. Kung gusto mag-home quarantine, picturean yung bahay na dapat may CR sa loob ng room. Yun. Next, but isolation may not just be for those who tested positive. The CDC also recommends those who have symptoms of COVID-19 and are waiting for test result or have not yet been tested or isolated, even if they do not know if they have been in close contact with someone with COVID-19. Under the CDC guidance, those in isolation should monitor your symptoms. If you have an emergency warning signs, including trouble of breathing, seek emergency medical care immediately. Then, stay in a separate room from other household members if possible. Use a separate bathroom if possible. Take steps to improve ventilation at home if possible. Avoid contact with other members of the household and pets. Don't share personal household items like cups, towels, and utensils. Then wear a well-fitting mask when you need to be around with people. These are the things you should do if you are in isolation. How do you know when your isolation will end? So you can end isolation after 5 full days if you are fever-free for 24 hours. Again, you can end your isolation after 5 full days if you are fever-free for 24 hours without the use of fever-reducing medication and your other symptoms have improved, such as the loss of taste and smell may persist for weeks or months after the recovery and need not to delay the end of isolation. If you continue to have fever or your other symptoms have not improved after 5 days of isolation, you should wait to end your isolation until you are fever-free for 24 hours without the use of fever-reducing medications and your other symptoms have improved. You have to continue to wear a well-fitting mask throughout the day. Then contact your healthcare provider if you have questions. Last, do not go to place where you are unable to wear a mask, such as restaurant, in some gyms, and avoid eating around others at home and at work until a full day, 10 days after your first day of symptoms. So if ever na-achieve mo lahat ito, you can end your isolation. So how do you calculate your isolation period? So ito yung sabi ko kanina. Day 0 is the first day of symptoms. So that means day 1 is the first full day after your symptoms develop. For those who tested in COVID-19 but have no symptoms, day 0 is the day of the positive test. So those who develop symptoms after testing positive must start their calculation over. However, with the day 0 then becoming the first day of symptoms. So, ganon, day 1, day 2, or how many days ka na mag-count. Kasi, di ba, mag-isolate ka or mag-quarantine ka for 5 days. Here are the vaccinations that are available for COVID-19. So, dili dyan ako siya i-rundown lahat ha. We'll just, these are already familiar with you. So, daanan lang natin itong mga vaccination. We have Pfizer or BioNTech. This is a mRNA technological platform. You will receive 2 doses and 10 to 1 days apart. For the AstraZeneca, this is a viral vector non-replicating technological platform, and this is given also for 2 doses with 4 to 12 weeks apart. For the Sinovac, this is an inactivated virus technological platform. This is given 2 doses with 28 days apart. For the Gamaleya Sputnik, this is a viral vector non-replicating technology platform, and this is given 2 doses with 3 weeks apart. For the Janssen or J&J, this is a viral vector non-replicating technology platform, and this is given 1 dose. For the Bharat Biotech, this is an inactivated virus, and this is given 2 doses with 28 days apart. We have the Moderna, the mRNA. This is given 2 doses with 28 days apart. Lastly, the Novavax or the protein subunit technology platform. This is given 2 doses with 21 days apart. So these are the vaccines that are available for COVID-19. With this vaccine, they will also experience side effects. So common side effects after receiving the vaccine, and these side effects will just go away. So patient will complain of pain on the injection site. Sometimes they will experience redness and swelling on the injection site. There will be tiredness or body malaise and headache. They will also experience chills, muscle pain, fever, and nausea. So these are just side effects, and they will go away within few days. So you have just to treat the signs and symptoms on what they are experiencing. Here is the therapeutic management of hospitalized adults with COVID-19 based on the disease severity. So
Okay, so ito, this was the old protocol. So I sent a copy of the new protocol. This started last January. So this is the present protocol that the DOH is implementing. So please kindly check the GC so that you can update. Can also attach that into into the PDF that you have right now. So mag-jump off na lang taaning management in the hospital, because this was the management during the peak of the COVID-19.
the ventilation. Then lastly, this is reduce the swelling in your blood. These are combined an example of a PPE. So preferred PPE use, the N95 or high respiratory. So same lang, no, we have face shield, N95, gown, gloves, no, and yeah, with acceptable alternative.
So this is the one that I think you are practicing in the clinical area right now, the use of PPE. So when you are having your duty, you have your PPE, no? Napamoy code color protocols. Pag manding, anong color. But now, we don't usually use na our face shield, no? Kasi all of us are already vaccinated. So, but when nurses be able to take care of COVID-19 patient, they have to still wear the face shield, no? Kayo, bawal kayo mag-take care, no? Gina-pull out kayo sa mga pulmonary diseases so that you'll not be exposed.
effective with the face mask only, it looks like this. Okay? So, in the area, no, kaya may PPE kayo kasi, ayan, to protect yourself. Sorry for that alarm. Next, here is the best way to protect yourself. You have to wash your hands frequently and thoroughly using soap, water for at least 20 seconds. Use alcohol-based hand sanitizer if soap and water aren't available. Please do cough or sneeze into a tissue or flex elbow, then throw the tissue into the trash cans. Avoid touching your eyes, nose, or mouth with unwashed hands. Avoid close contact with people who are sick, sneezing, or coughing. Stay at home when you are sick. Clean and disinfect surfaces and objects people frequently touch. Then, only wear a face mask if you have respiratory symptoms or caring for someone with respiratory symptoms. Yan. So, the virus usually spread from close person-to-person contact through respiratory droplets from coughing and sneezing. The virus may be also spread through airborne transmission, where tiny droplets remain in the air even after the ill person leaves the area. So, symptoms may develop within 14 days of exposure. So, ang latest ngayon, di ba? Pwede magpakita or ano na until 10 to 14 days. Di na before na mag-abot talaga ng 14 days of quarantine. Only designated laboratory tests can diagnose the virus. Ngayon, marami na masyadong testing centers. What can you expect to happen during contact tracing if you have been diagnosed?
Okay, we'll move forward on the next disease, which is the MERS-CoV. We will not discuss further with the COVID-19 contact tracing because you already know about this one. How or what will you do if you are positive? But now, iba na yung protocol ngayon. Usually, the people are encouraged to do isolation and quarantine sa bahay na. Hindi na sila ginakuha, no? Ayan, sa bahay na lang because everyone or most of us are already vaccinated. Okay, so let's move forward to the discussion of another respiratory disease, no? I think I'm not kung graders pa siguro mo ani ng mga panahon, no? When this happened. So we will talk about next is the MERS-CoV virus.
Is the Middle East Respiratory Syndrome or coronavirus or MERS-CoV. So, Middle East Respiratory Syndrome is an illness caused by a virus, more specifically a coronavirus called MERS-CoV. Most MERS patients develop a severe respiratory illness with symptoms of fever, cough, and shortness of breath. About 3 or 4 out of every 10 patients report with MERS have died. So, through the first report, first reported in Saudi Arabia, it was later identified that the first known MERS occurred in Jordan in April 2012. A large MERS outbreak occurred in the Republic of South Korea linked to a traveler from Arabian Peninsula in 2015. So MERS-CoV likely came from an animal source in Arabian Peninsula and in humans. In addition to human, MERS-CoV has been found in camels in several countries. It is possible that some people become infected after contact with camels. So, pwede tayo ma-infect through direct contact with the camels. So, the camels are the intermediate hosts of this MERS-CoV. MERS-CoV, like other coronavirus, is thought to spread from an infected person respiratory secretions such as through coughing. However, the precise ways the virus spread are not currently well understood. MERS-CoV has spread from ill people to close contacts such as caring for a living with infected persons. So, first, this is from the bat coronavirus, and then direct contact with this ill or bats no, that are ill. The camels that are come contact with them will be the intermediate host of the MERS-CoV. Then the person will be direct contact with the camel will be a receptor. And then if this person will be infected, they will scatter the virus through droplets and direct contact no? And another human being who will expose will be having this kind of virus. So clinical manifestation. The symptoms of MERS starts to appear 5 or 6 days after a person is exposed. Again, 5 or 6 days after a person is exposed. But it can range to 2 to 40 days. So most people confirmed to have MERS-CoV infection have had severe respiratory illness with symptoms of fever, cough, shortness of breath, and some people also had diarrhea and nausea and vomiting. Some laboratory confirmed cases of MERS-CoV infection are reported as asymptomatic. So meaning that they do not have any clinical symptoms. Sorry. Yet they are positive for MERS-CoV infection following a laboratory test. So most of these asymptomatic cases have been detected following aggressive contact tracing of a laboratory that is having confirmed case. So we can have the diagnostic test, no, RT-PCR assay, serology, yung antibodies, and then chest X-ray. Next, for am I risk for MERS-CoV? Risk for MERS-CoV infection including those are recent travelers from the Arabian Peninsula, people who have had close contact such as caring for and living with an ill traveler from Arabian Peninsula, people who have close contact such as caring for and living with confirmed case of MERS-CoV, and then healthcare personnel who do not use recommended infection control precautions, then people who have or had contacts with camels. So those are the people who are at risk for having MERS-CoV. Is there a vaccine for MERS-CoV? There is currently no vaccine to protect us against the MERS-CoV. For the medical surgical management, no vaccine or specific treatment is currently available. Although several MERS-CoV specific vaccines and treatments are in development, treatment is supportive and based on the patient's clinical condition. Kung ano yung na-experience sa patient, yun lang din ang treat. As a general precaution, anyone visiting farms, market, barns, and other places where dromedary camels and other animals are present should practice general hygiene measures, including regular hand washing before and after touching animals and avoiding contact with sick animals. The consumption of a raw or undercooked animal products, including milk and meat, carries a high risk of infection that can cause disease in humans. Animal products that are processed appropriately through cooking or pasteurization are safe for consumption, but should also be handled with care to avoid cross-contamination with uncooked foods. Camel meat and camel milk are nutritious products that can continue to be consumed after pasteurization, cooking, or other heat treatments. So the transmission of virus has occurred in healthcare facilities in several countries, including transmission from patient to healthcare providers and transmission between patients from MERS-CoV was diagnosed. It is not always possible to identify patients with MERS-CoV early or without testing because symptoms and other clinical features may be non-specific. So for our nursing responsibilities, wash hands often with soap and water for 20 seconds. If water and soap are not available, use alcohol-based sanitizer. Practice etiquette or respiratory etiquette, how to cover your nose and mouth with a tissue or the inner elbow when coughing or sneezing. Avoid touching your eyes, nose, and mouth with unwashed hands. Avoid close contact with sick individuals, such as kissing, sharing cups, or sharing your eating utensils. Then clean and disinfect frequently. Touch surfaces such as toys and doorknobs. Prevention step for people confirmed to have or being evaluated for MERS-CoV infection. So, number one, if you're confirmed to have or being evaluated for MERS-CoV infection, you should follow the preventive or the prevention steps below until a healthcare provider or local or state health department says you can return to your normal activities. So, number one, you have to here stay at home. You should restrict activities outside your home except for getting medical care. Do not go to work, school, or public areas, and do not use public transportation or taxis. Next, separate yourself from other people in your home. As much as possible, you should stay in a different room from other people in your home. Also, you should also use separate bathroom if available. Next, call ahead before visiting your doctor. Before your medical appointment, call the healthcare provider and tell him or her that you have or are being evaluated for MERS-CoV infection. This will help the healthcare provider office take steps to keep other people from getting infected. Last, wear a mask. You should wear a mask or face mask when you are in the same room with other people. And when you visit a healthcare provider, if you cannot wear a mask, the people who live with you should wear one while they are in the same room with you. Next, cover your cough and sneeze. So cover your mouth and nose with a tissue when you cough or sneeze, or you can cough or sneeze into your sleeve. Throw used tissues in the linen trash or in the lined trash can and immediately wash your hands with soap and water for at least 20 seconds. Wash your hands often or thoroughly with soap water at least 20 seconds. You can use alcohol-based hand sanitizer if soap and water are not available and if your hands are not visibly dirty. Avoid touching your eyes, nose, and mouth with unwashed hands. 8. Avoid sharing household items. Should not share dishes, drinking glass, cups, eating utensil, towels, beddings, and other items with other people in your home. After using these items, you should wash them thoroughly with soap and water. Monitor your symptoms. Seek prompt medical attention if your illness is worsening. Before going to your medical appointment, call the healthcare provider and tell him or her that you have been evaluated for MERS-CoV infection. This will help the healthcare provider's office to take steps to keep other people from getting infected and ask your healthcare provider for to call local or state health.
Okay, so I'll continue with the respiratory disease. Hold on, I'll share my screen. Okay, so I think those are just protocols. Gibutang lang ko na ko na dera for nice to know. At least if you will be able to experience, ay lain po na experience ma'am, no? Kay murag delikado man, but if you'll be able to handle patients, no, you'll know what to do. So, let's move forward sa SARS. Okay lang ha. Yan, can you see my slides, class? Yan, preparing pa. Thank you so much. So we'll proceed with SARS. What is SARS, class? What is the meaning of SARS? Now, what comes into your mind? Have you heard this one? No, familiar ba tayo? SARS means severe, acute, respiratory symptoms, no? This happens way back in February 2003 pa sa China gihapon, class, no? So amot kung unsa mong anak na ba mo aning 2003 or wala pa. So kani siya, this happened way back before in February 2003, and it started in China and then spread in 4 countries. So the incubation period of the SARS started from 2 to 7 days, no? But it lasts as long as 10 days, no? How does SARS no spread? Usually, the main way of SARS to spread is spread is close person-to-person contact. The virus that caused SARS is thought to be transmitted most readily by respiratory droplets, no, or droplet spread produced when an infected person cough or sneeze. So same lagi na silang tulo, no? COVID-19, MERS-CoV, careful job with cough etiquette and sneeze etiquette, no? So they are transferred via droplets. So usually when the person is so near to you, dapat ay dali siya ma-expose. So when we say near or short distance, it means 3 feet, no, near to you. So when you are that near, you can get the you can receive the droplet, no. So that is why way back before, gina-encourage jud na mag-face shield ang mga tao. Okay? So the virus can spread when a person touches a surface or object contaminated with infectious droplets and then touches his or her mouth, nose, or eye. So in addition, it is possible that SARS virus might spread more broadly through the air or airborne spread or may be otherwise that are not known. So what does close contact mean, class? So close contact means is when you are hugging, kissing, sharing eating utensils, drinking utensils, talking to someone without PPEs within 3 feet, and touching someone directly. So those are the close contacts. So close contact does not include activities like walking a person or briefly sitting across a waiting room or office. So dili na siya ginaingon na close contact if that is the case. But pag close contact, na joy touched with a person, no, or super near with that person. What are the clinical manifestation of SARS? So first, symptom of the illness is generally fever. Fever as high as 38 degrees Celsius, which is so high na yan, class, no? And this is associated with chills and rigor. So it may be also accompanied with headache, malaise, and muscle pain or weakness, no? At the onset of the illness, some cases have mild respiratory symptoms. Some people also develop rash, and neurological and gastrointestinal findings are absent. So after 3 to 7 days, no, a lower respiratory phase begins with the onset of a dry, non-productive cough or dyspnea or shortness of breath that may be accompanied by or progress to hypoxemia, which means low blood oxygen levels. In 10 to 20% of cases, the respiratory illness is severe enough to require intubation and mechanical ventilation. So, the chest x-ray may be normal throughout the course of illness, though not for all patients. They also check the WBC, no, because it decreases early in the disease, no. They shows low platelet in their CBC. So our medical management, no, with the SARS, there's no cure or vaccine for SARS, and treatment should be supportive and based on the patient's symptoms. Kung sa iyang symptoms karon mo po natong i-treat. Like for example, no, the fever, if the patient is having fever, our management will be giving of antipyretic and TSB. So prompt detection of these cases through good surveillance network and including an early warning system should be done, no, para dili siya mag-scatter fast. Contact tracing and those who quarantine should be done always. So, yun na yun. I think we are familiar with that already, no? Balik-balik lang yun ni siya. So, for our nursing management, no? Always remember, cover your mouth when you are coughing, no? So, these are our cough etiquette. If you do not have a hanky or tissue, you can use your elbow or sleeve to cover your mouth, no? And always wear your mask. You wash your hands regularly. So, with nursing management, we have to use personal preventive measures to prevent the spread of virus, including frequent hand washing. Okay, and for those high risk, such as us, the healthcare workers, no, we have to always use our PPEs, including the mask, goggles, and an apron, and which is our mandatory PPE. So whenever possible, household contact should also wear a mask. Yon for our SARS. Let's move forward for our pulmonary arterial hypertension. No? So what is pulmonary arterial hypertension? This occurs when the arteries that carries the oxygenated blood from the heart to the lungs become narrowed as a result of changes in the lining and smooth muscles of the vessel. So the result is elevated pressure in the pulmonary artery, thus causing the right ventricle to work harder to push blood into them. So eventually, the right ventricle fails, thus leading to cor pulmonare. So the reason for these vascular changes is not known. So primary PAH is more common in women between ages 20 to 40 and has a hereditary tendency. So again, class, for pulmonary arterial hypertension, when you say pulmonary in your pulmonary artery, no, that is your when you say pulmonary arterial when you say PAH or pulmonary arterial hypertension, the pulmonary artery are thickened, no? Because of the thickness, this affects the pressure inside your lungs and the heart. So kung too much pressure, no, mas nag-effort ang heart para i-pump, thus causing it to be tired, makapoy po ang atong right ventricle, no? So this will affect, no, our patient. So the clinical manifestation of patients who have PAH is dyspnea, fatigue, crackles, decreased breath sounds, ventricular edema, distended jugular veins. Angina may result from the ventricular ischemia because of the too much effort of our right ventricle. So our pulmonary arterial hypertension class is one of a broader condition known as pulmonary hypertension. So pag sinabing hypertension, ano pumapasok sa isip nyo? Taas ang blood pressure. So asa man? In your pulmonary, no, in the lungs. So the increase in the pressure in the vessels in the lungs causes, no, the thickening and causes obstruction, and the heart will try to compensate more, no? So our nursing management, no, for this pulmonary arterial hypertension class is collaborative and focuses primarily on the patient's assessment. So we have to reposition our patient, either Fowler's or high Fowler's, to reduce the dyspnea And rest and comfort measures are helpful in treating fatigue and anxiety. As you can see in our photo on the right side, class, as you can see, no, the pulmonary arteries, blood vessels is like this normally. Oops, wait. Yan. Ayan, no? So, very widened talaga, no? Ang ating blood artery, blood vessels, or our pulmonary artery. What happened in the PAH is there is constriction, no? So, the blood flow is lessened, no? Or slowed na papunta sa lungs. So, your heart will try to compensate to push more blood, no? Thus, causing also right ventricle failure. Yan. So, our medical management, no cure is available for pulmonary hypertension except for lung or heart transplant, no? So, ito, mahirap ito kasi in our country, hindi po common ang mga ganitong transplant. Pero meron, pero not commonly done, no? In secondary pulmonary hypertension, the underlying disorder is treated. So, kung ano yung primary disorder, no? You have to identify and treat also the secondary disorders. Supportive care includes a low sodium diet and diuretics, no, to reduce blood flow and therefore reduces also the pressure. Oxygen and cardiac monitoring should also be done. Our vasodilators, such as our calcium channel blockers or our ACE or angiotensin converting enzyme inhibitors may be used to reduce the pulmonary artery pressure. So, pampababa because this ng ang pressure because this is leading to vasodilation, no? Warfarin may be used to prevent clotting, and Flolan is a vasodilator that may reverse some of the vascular changes and prolong survival but has many serious side effects and must be continuously administered IV via implanted pump. So, dapat naka-pump talaga ito siya kasi dangerous if mahatag po siya too much. We have also the Tracleer. This is a new oral drug that blocks endothelin, a substance that causes blood vessels to constrict. So those are our medical management for our PAH. Next disease is the pneumothorax. No, I think this is the second to the last, or second to the last or last disease or second to the last topic. So sit tight lang yapon mo da class ha. Are you still there? No, I hope that you're still listening. So pneumothorax is one of the very scary diseases, no? Bakit? Because when you say pneumothorax, it means that there is air or gas accumulation between your parietal and your visceral pleura, causing the lungs to collapse, no? Pag sinabing lung collapse, that's scary, very scary because it will lead to problems in the breathing of your patient. Accumulation of atmospheric air in the pleural space which result in a rise in the interthoracic pressure and reduce the vital capacity. So when you say pneumothorax, our clinical manifestation for that is sudden pleuritic pain. Kalit lang, no? Sakit niya, anxious, dyspnea, or what we call the air hunger. The use of accessory muscles, cyanosis, when nag-bluish discoloration na ang patient, tachycardia, the compensatory mechanism of our heart, profuse diaphoresis, and asymmetrical chest wall expansion. Kindly include class, no, our tracheal deviation, no? When we say tracheal deviation, no, mag-deviate siya to the other side because papasok na yung air dito sa lungs, no? Mamumove na yung lungs natin on the other side. So, that would also include your trachea. So, for our diagnostic test, we have our chest x-ray and our ABG. Chest x-ray will help give us a view inside of the lungs, no? And then the management is either we have thoracentesis, CTT, thoracotomy, or pain reliever. But before we go to that, let's also know what are the different kinds of pneumothorax. We have the simple pneumothorax. A simple or spontaneous pneumothorax occurs when the air enters to the pleural space through a breach of either the parietal or the visceral pleura. Most commonly, this occurs as the air enters the pleural space through a rupture of a bleb or bronchopleural fistula. We have another one, which is our traumatic pneumothorax, no? Pneumothorax yan. Now, traumatic pneumothorax occurs when air escapes from a laceration in the lung itself and enters the pleural space or from a wound in the chest wall. It may be a result from a blunt trauma. Example niyan is the rib fracture or penetrating chest or abdominal trauma such as your stab wounds or gunshot wounds or a diaphragmatic tear. So that is your traumatic kasi meron tayong no penetrating no or merong nasaksak sa patient or stab no in the chest. We have also our last tension pneumothorax. Tension pneumothorax occurs when air is drawn into pleural space from the lacerated lung or into the small opening or wound in the chest wall. So when we say pneumothorax class, it is classified into open and closed pneumothorax. From the word itself, it will guide you to understand it more. When you say open pneumothorax, it means open. So there air can be entered and escaped through the opening into the pleural space. As you can see in the photo below, class, this one, you can see that there is an opening on the lung. No, so it means that is an open pneumothorax. There is a hole, no, that can the air can enter into the lungs and the escape also of the air from the lungs out to the atmosphere. We have what we call also the closed pneumothorax. From the word itself, closed, no, walang hole, no. Thus are the air cannot be able to escape, no, so there is no hole present no in the area. We have also what we call hemothorax class. When you say hemo, no, class is it means blood, no, blood ang nagpasok sa ating lungs. We have also what we call fluid class. That is what we call the pleural effusion. Okay, pag pneumo, there is an air, no, in the lungs. So the term hemothorax refers to the presence of the blood in the pleural space. So this occurs with or without accompanying pneumothorax or hemopneumothorax and is often result as of the traumatic injury. So, pwede siya masabay. It's either meron presence of air also at the same times with the bleeding. So, let's move forward for our management with this kind of problem. So, we have our chest tube drainage. No? Chest tube drainage system have a suction source, a collection chamber for pleural drainage, and a mechanism to prevent air from re-entering the chest with inhalation. And there are various types of chest drainage that are available. As you can see, class, no, I do not know if you have encountered this in the clinical area. This is common in the surgical ward, which is our San Lorenzo ward. Also in the ICU, this is very common. So as you can see, this is our drainage system. So we have different kinds of drainage. This is the old one, no? We have our bottle system. We have our two bottle system and three bottle system. The common sense will tell you why tawag siya one bottle. Kasi one bottle lang po siya class, no? Pag two bottles po ang ginagamit, no? Okay, so as you can see, because of the innovation of our medical field, now we have what we call Pleurovac. Pleurovac is like this class, no? This is a plastic container that will divide this is a plastic container in which in one plastic container there is already three bottle system or sa isang container naka-separate na yung three bottle drainage system natin. So ayan, let's move forward. Yeah, so this one is focus muna tayo sa ating so ito, this is our Pleurovac, no? So you can see this one in the clinical area, no? But before that, you have to also understand the different parts of the three bottle system. Balik lang tayo dyan later, no? So this is our three bottle system. Our patient who has a pneumothorax, like for example, gidunggab, no, sa chest, no, tapos gibira pagyod, no, ang kutsilyo. Pagbira, so there will be traumatic pneumothorax. So there will be air, there will be blood inside the lungs, no. So because of that, no, Ang management na to remove the blood, to remove the air in the lungs, is to attach a chest tube drainage, or what we call CTT, no? So CTT, no, have different kinds of drainage, and I will tell you the 3 bottle system drainage. Kasi this is one of the questions usually na ginatanong sa board exams, no? So first is this tube is attached to our patient, no? So the tube will be attached to a bottle. So always dapat ang bottle, the 3-bottle system or any bottle should always be below from the patient side. Okay? Dapat naano siya sa salog or sa baba. Okay? Yan. So first, no, this is the attachment for our patient na siya bleeding, no? So mugawas na siya diri asa ato ang what we call the drainage bottle. This is our drainage bottle. From the word drainage bottle, common sense again will tell you that dili mo tapok tanan na na-drain mo inside the lungs of our patient. Okay? The drainage system, no, meron yan siyang calibration class, no? Meron yan siyang calibration. When you say calibration, ay nakabutang 100, 200, 300, 400, or in short, what we call measurements. Why is that? Because it is important that we know how much is drained to our patient. So usually, when you have your duty, if you know that your patient is on CTT, your nursing, very important nursing responsibility na wag mong kalimutan, mamalihog ko, is check the current level of your CTT. So kung 7 to 3 ka, alas 7, na-adri na level, pag uli ni mo alas 3, na-adri ang level. So you have to take note how many blood, no, was released in your drainage bottle. So there will be calibration and you'll be able to measure how many is the output kasi kasama yun siya sa INO mo. Okay? So please, do not forget because nurses nowadays, ito po yung common mistake nila. Hindi nila alam at mabilis sila matakot, no? If you know if you're doing is right, no, and you know what is your nursing responsibility, no, please do not forget it. Okay? So again, our first bottle is our drainage bottle or what we call our collection chamber. So this collection chamber collects the fluid from the lungs or our serous drainage. Next is what we call the second bottle is what we call our water seal bottle. Water seal bottle from the word itself, water seal. So as you can see, no, in the photo that there is water, no, and it is sealed. Ma'am, paano po mo nasabi naka-seal? You can look at the tube, no, this tube, it is submerged under the water. So that is why, that is another way on sealing, no, the air inside the water. So, dili na makasulod ang air sa tube kasi merong seal na water. Pero, pwedeng makalabas yung air from the tube palabas doon sa water. Pero hindi siya pwede makapasok. So, when you see water seal chamber, this is filled with water. And the purpose is to prevent air from entering to the chest. Pwede lang magawas og air from the chest pagdulong sa system, sa ating bottle system, pero bawal ang magsulod ang air padulong sa balik sa lungs ng patient. What are the important things that you have to take note with the water seal bottle? You have to always check the fluctuation. When you say fluctuation, class, that is what we call the tidaling of the water. Do you know what is tidaling, no? If you went to a beach, no, ato mo dagat, magtanaw mo wave, di ba? Wave man na balod sa Bisaya, no? That is tidal, di ba? Tidal wave. The up and down of the water in the ocean. So that is what we call tidaling. In relation to that, here in our bottle system, the tidaling is located here, no, inside the tube. Ma'am, diha ka sa sulod? Yes, there will be water inside here and mag-up and down na siya, class, ana. So, you have to take note if there is a presence of tidaling, which is the rise and fall of the water inside the tubing. Class, always remember, no, pag mag-inhale ang patient, no, mag-rise na siya. Pag mag-exhale, mag-fall po siya. Sa kanaog na siya if the patient is having his or her breathing, no? So with the bottle number 2, which is our water seal bottle, no, you have to always take note of the bubbles, no? Anong importante ng mga bubbles, class? Importante ito mga bubbles, no? Ito yung usual nung tinatanong sa board exams. So, when we say, no, the water bottle, there should be a presence of intermittent, no, bubbles. So, this is a normal continuous bubbling, no? Sorry, yes. Oh, yeah, bubble. So, because if there is bubbles should be intermittent, no? As you can see in the photo, class, ang mga bubbles niya, hinihinay lang, no? Intermittent lang ang pag-bubbles. Pag makita mo na magbula-bula na grabe ang bula-bula, it means that there is continuous bubbling, it means that there is leaking, no? Pag, sige, magbula daghan kayo, it means that there is leaking. So, careful po kayo, okay? Next, when we proceed with our third bottle. Our third bottle is what we call our suction bottle. Bakit sinasabing suction bottle? Kasi the third bottle is attached to a suction. A suction is maintained with a slow amount of suctioning lang. Dili siya kusog kayo ng suctioning. Slow lang ang yung suctioning. So that is why it's called suction bottle. So here in our suction bottle, there is a amount or level of suction in which the bubbles are gentle only. Gentle bubbling lang ang present dyan. So, when your nursing responsibility for patients who have CTT class is this one, no? Assessment. Always check the breathing of your patient. Check the breathing of your patient if takip niya, normal ba? You also have to check the breathing sound, no? Baka, no, nag-expand na balik ang lungs sa patient na drain mo na lahat. Or check if there is presence of crepitus or drainage, no, on the site of attachment. You have to also check the level of drainage upon receiving and endorsing. Ito yung sinabi ko sa iyo kanina. Class, always remember, the color of the blood that usually output niyan, class, is dark red. Pagka na, class, bright red, kaguol na, it means that is a fresh blood. And you have to refer it if it's bright red. And another one, you have to refer if the amount of the output is more than 100 cc. So nag-duty ka, nag-output nimo 100 cc more than, and bright red pag yun. So please do not forget to refer it. Okay? Next, you always have to check your bottle system or your drainage system that there should be no leakage, no? Kasi kung mag-leakage, pwede magpasok yung air sa lungs balik ng patient. Imbis ang purpose natin, tanggalin natin yung mga fluid at air sa lungs ng patient na atmospheric air. So, nagpasok na noon. Okay? So, ayan. You have to check for leakage or clogging on the drainage bottle or drainage system natin. You have to make sure that there's no milking of the chest tube, and always naka-place ang drainage system natin below the chest level or the site of insertion. When you have a CTT class, no, ito yung always question also, no? What are the things that should be present at the bedside, no? You have to remember this, class, no? Kasi if there is an emergency, you'll know what to do, or what are that you have preventive, no, equipments that are already present in the bedside. So we have your Vaseline gauze, the forceps, and our sterile gauze, no? So, yeah, yun ang always present sa bedside. Sterile water also. Sorry, sterile gauze man ang kabutang. Sorry. Erase yan. But what I mean is sterile water. Again, Vaseline gauze, forceps, and sterile water. Your nursing responsibilities is apply a non-porous dressing over an open chest wound. Monitor vital signs for indication of shock or increased respiratory distress. Administer oxygen as prescribed and place the client in a Fowler's position. Prepare for chest replacement, which means which will remain in place until the lung has expanded fully. If the chest tube is in place, encourage the patient to cough, breathe deeply at least once per hour to promote lung expansion. In the patient undergoing chest tube drainage, watch for continuous air leakage or bubbling in the water seal chamber. This indicates that the lung defect has failed to close and may require surgery. Observe for increasing subcutaneous emphysema by checking around the neck at the tube or the insertion site of the crackling beneath the skin. So, discuss ko yan. Basahin lang muna natin. If the patient is on a ventilator, be alert for any difficulty in breathing in time with the ventilator. As you monitor, it gauges the pressure increase. Change dressing around the chest tube insertion site as needed and as per facility policy. Don't reposition or dislodge the tube. If the tube does dislodge, immediately place a petroleum gauze dressing over the opening to prevent rapid lung collapse. Observe the chest tube site for leakage and note the amount of color or drainage. Okay, makinig kayo. So, this is your patient, no? Remember, you have your chest tube drainage. Okay, yan. That is your drainage, no? Tatlong bottle yan. So, what will happen if you have a patient, no, na nag-bedside kayo, no? Naibot ang atuang CTT, no? Yan. Naibot imo si TT from the insertion site. If naibot ang imuhang tubing from the patient, you have to get the vaselinized gauze, no? Yung gauze na sinabi ko that should always be present in the bedside of your patient. Get the vaselinized gauze, cover it to the insertion site or the whole of the insertion site of your CTT. Place a plaster. 3 sides only, class. So let's have 3 sides. 1, 2, and 3. Why is it 3 sides lang? Para yung air hindi na makapasok doon sa hole. But pwede lang maka-escape yung air from the lungs to the atmospheric pressure. Kaya hindi natin gina-close yan 4-sided, no? Pwede lang siya 3-sided lang ang ating attachment of the gauze or vaselinized gauze. Ma'am, nga man, dili pwede na ordinary gauze. Because our ordinary gauze is porous, no? May mga holes. So, it does not help in sealing, no? Our OS, ganyan-ganyan yan, di ba, class? So, meron siyang buslot-buslot. So, it will not help in the sealing of our insertion site or yung ating hole or wound or CTT insertion site. So, kung ibutangan mo ordinary na OS, makagawas sulod gapon ang air, no? So, when you place a vaselinized gauze, this is non-porous. Wala talaga yung buslot class, no? So, ilagay yun sa side para hindi makapasok labas yung ating air. But you have to attach only 3-sided. So, pag matanggal ang tube sa patient, cover the wound or insertion site with a vaselinized gauze. Okay? Next, another scenario is if the patient sorry. Ay, wala na. Drawing tayo ulit. This is your patient, no? This is your drainage system. This is your tubing, no? And, naibot ang imuhang tubing from the drainage system, no? Nag-rounds ka, nasikaran nimo ang bottle system. Pag sikat nimo, naibot ang tubing sa imong drainage system. What will you do, no? So, this is very dangerous, class, because the air might go inside to the tubings and go inside to the patient's lungs. So what we do is, that is why it's important that we have our bedside bottle, we have our bedside equipment. So, our bedside equipment is usually we have our sterile water, no? Our sterile water, no, should always be present in our bedside. So, you submerge your end of the tubing into the sterile water. So, nag-act siya as a water sealant. Class ha? Again, you place your sterile water and submerge it in, you place the tubing or the end tubing of your CTT to the sterile water so that it will act as a water sealant. So that the atmospheric air will not go inside to the tubing para moadto sa lungs sa patient. Okay? So this will prevent the air from entering inside the lungs, no? And we do not recommend you to do milking. You're not allowed to do milking. Might as well clamping, especially no pag mag-transport. Bawal ginaklamp ang atong CTT pag mag-transport. When clamping is done, it should be ordered, no? There should be doctor's order. Okay. When will you know if the lungs of the patient is already expanding, no? Ay, naka-recover na. You'll know by the x-ray, the drainage, kung wala na masyadong nagalabas, no? And the fluctuation or our tidaling. So, kung di na siya nagasaka na, you have to double check, no? If nag-re-expand na ang lungs, so dili na siya mag-tidaling. Pero, be careful also, pag hindi na mag-tidaling, because there are also signs that merong obstruction. Baka may clot formation, kaya nag-obstruct, kaya hindi na din nag-tidally. So, at least, you have to please check first before removing, no? Ang mag-assist kasi tayo niyan in the removing. And when there is already, no, regain of the lung expansion of your patient class, no, we will have to remove the CTT. So, yay, remove na ang CTT. So, you will be the one who's gonna assess, no. Your nursing responsibility to the patient is to remind him na mag-valsalva during the removal. Sir, no, inhale, exhale, and then you utong, no, or exhale to the utong or ano yung tawag niyan Valsalva maneuver or exhale up to the last breath mo talaga. And then the doctor will remove the tube. Okay? Then, after removing the tube, no, packing of the insertion site. So, ipack ng maayos para hindi na magbalik na makapasukan na ulit ng air. Okay? So, ayan. So, I hope that na-understand ba, class, ang atong CTT? Heart comment daw kung naintindihan or napabamudra. Yan, thank you so much. Class, trust me, this is a very common question in the board exam. Masing asa pa ka na board exam mo adto or asa pa ng klaseng exam, mapa-quiz, ma-exam, board exam, NLE, no? It's pneumothorax is one of the questions na CTT na agid na sila na question. And libaon gid mo ana. Okay? So be careful. Okay? You just have to have a good sense of common sense lang yun and know your nursing responsibility. So that is your pneumothorax. I-discuss ko lang itong ventilator alarms. Short lang talaga ito, class. This is the last topic. So, when you see ventilator alarms, this is what we called our mech vent, no? Kasi magjo-duty kayo ng ICU. So, baka mapagalitan tayo, hindi ko naturo ang ginatawag natin na ventilator alarms, no? Mech vent has a settings. Ito yung mag-ingay, mag-alarm yung atong mga machines because there is a problem, no? When they do alarm, maingay masyado yan. Anak kasaba class, no? So, pag makita nimo nag-alarm, you check if what kind of alarm is present in the machine. Kita man na nakabutang high pressure alarm. High-tech naman karon ang atong mga mech vent, no? Naanay mga signals, naanay nakabutang ng mga words. High pressure alarm, low pressure alarm. Sa una, wala man gud na mga wala yung mga nakasulat, no? Ang tan-awon lang nimo ang pressure dito sa machines. Kung di ka kabalo magbasag pressure, so dili mo ma-identify if it's a high pressure or low pressure. So nevertheless, because easier na atong life, pag high pressure ang nakabutang dito, class, the thing that comes into your mind should be there is a presence of high pressure. So when is it that there is a presence of high pressure? When the patient is coughing, gagging, bronchospasm, fighting the ventilator, or there is ADT occlusion, kink in the tubing, increased secretions, thick secretions, and water in the ventilator circuit. Pag sinabing low pressure alarm class, no, there is a low pressure within the patient. Bakit? Kasi because there is a tubing disconnection, loose connection, leaking, extubation, cuff, ET, or trach is deflated, and poorly fitted CPAP or BiPAP mask. Okay, for you, easy to remember, pag sinabing high pressure, ay pag high pressure and low pressure alarm class, pag L, that means low pressure, and always comes into your mind, leaking. Okay. Pag merong leaking class, it means hungaw, no? Hungaw. So that is why merong escape of air, kaya konti lang yung pressure na nagapasok sa patient. So that is why mag-alarm siya. So like, naibot, no? Merong natanggal, merong loose connection, kaya naga-low pressure alarm siya. So ang papasok sa utak, pag low, 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 leak, leak, leak. There is a leaking of the air. Pag high pressure alarm class, no? High, always come into your mind obstruction. No? High pressure, it means obstruction. Bakit? If there is an obstruction class, mag-increase ang pressure, manggod, kasi wala na siyang daanan kasi merong blockage. So, example of our obstruction is mga ginapaak ni patient ang iyahang endotracheal tube. Pag mapaak ang tube, dili na maka-escape ang air og tarong. So, pag muhatag ang mekbet og hangin para sa patient, gipaak niya ang tube, so mo-alarm si patient kasi merong obstruction. Another one is secretions, no? Daghan kaayog plema si patient, no, sa iyang tubing. So if there is plema, anya ni kaging pagyod, so sige, high pressure alarm because of the obstruction. So yun lang ang isipin ninyo, and it will guide you, no, para easier, para it will guide you to identify what is the cause. If you will see high pressure alarm, what are you gonna do? Your nursing responsibility is to check asa ang reason o sa ang cause sa high pressure alarm. And if it's occlusion or obstruction, you have to release, no? Kung for example, na-kink lang, release. Para mga secretions, you suction. Ganon. Okay? Remove the obstruction in short. Okay? If it's a low pressure alarm class, ano nga papasok? Leak, leak, leak. There is a leakage of the air, no? Naayhungaw, naibuslot. So if there is a leakage, you have to close it, no? If it's a tubing na detached or na disconnected, i-connect lang siya balik. So if it's a loose connection, hanapin mo yung loose connection and ibalik lang din siya para ma-enclose na wala nang leakage. Okay? So kung loose lang siya or deflated, you have to inflate para masil yung air inside the tubings. Okay? So I think that is all, no? Yun lang remember niyo, so that when you're in the clinical area, dili makurat-kuratan, no? Pag mutingog ang neck vent. Kung mga estudyante before, mura magkahilakon pag makadungog og neck vent na alarm. So for you to be able to be an efficient nurse, you should be friendly with the alarms, no? You should know all the kinds of the alarms of the machine so that can manage your patient properly. So I think that is all. It's already 7:27. I have already finished the respiratory system. Thank you so much, class. No, I hope that you are still there. No, congratulations, we finished the respiratory system. I'd like to remind everyone that we'll have a quiz on the foundation and the respiratory system on our next meeting on October 12th, Thursday. Okay? That will be a face-to-face meeting, no? Yan, mag-quiz po tayo, long quiz po yan. So please do study. I think I have provided you with the notes, so please do study and additional information for the COVID-19. So I think that is all, class. Thank you for listening.